பக்கத்துலயே.
Hi, sir.
Hi, hi, hi. How are you?
Fine, sir. Doing well.
Yeah, so happy to see you.
Thank you, sir. So we'll go live, sir, now.
Yeah,
The first case is ready. We'll go on live, sir, now.
yeah.
Sir, first case will be right left, sir. Can you hear me, sir?
Not clear.
Hello, Dr. Bharat.
Sir, good morning.
Good morning, Dr. Bharat. Good morning.
Sir, can you see me or voice is audible?
கொஞ்சம் வாய்ஸ் கிளாரிட்டி மட்டும் கொஞ்சம் இதா இருக்கு மிஸ்டர் பீட்டர். இந்த வாய்ஸ் கொஞ்சம் அட்ஜஸ்ட் பண்ண முடியுமா? யுவர் வீடியோ இஸ் வெரி நைஸ். ஆடியோ இஸ் a bit
You are seeing the outside view, sir.
yeah, we are seeing outside. You are seeing you, Rajiv, and the team.
Yes, sir. Sir, good morning to everyone there. So today, the first case, we are going to start with inguinal hernia. This is not a classified hernia because it's a complete sac. According to the classification, when the hernia is going touching the mid thigh, then only it will enter into the classification. It's a complete sac. There are two ways of approach B. One is the TEP and another one is TAPP. So what we are going to do now is a TEP, that is totally extraperitoneal repair for this complete inguinal hernia on the right side. Case details is almost 40-year-old female presented with the right groin swelling. No significant, apart from that, no significant history. You can see the outside view. First, for the outside view. Top light நிறுத்துங்க. தெரியுறதா outside view? Sir, can you get the outside view now?
Yes, Dr. Bharat. Yeah. We're able to see the.
You able to, whether you can able to see the markings here?
Yeah. Can you please explain the markings? What are they for?
So this is the umbilicus, and you
Okay.
can see one more marking here and here. This is
Yes.
for telescopic trocar. Through the subumbilical approach, we are going to go inside, create the retrorectus space, put the first trocar here. You can see the line here. This is an
Yeah.
arcuate. So above the arcuate, the first trocar will be entered, the right working trocar.
Okay.
With this, the right retrorectus space will be created. That is your space of Regius. Once we
Okay.
created, we cross over the lower midline. There is a lower midline crossover. Then
Okay.
we access to the other trocar here. You can see the seminal line here.
Okay.
We are not going to breach the seminal line. So we are going to dissection B around here. Once we create the space, the three trocars will be in place. We'll go to the head end of the patient. You can see here the linea, what we measured, just marked above the umbilicus here. Why I marked this?
That you do with an ultrasound, huh? That you do with an ultrasound?
Yes, sir, we did an ultrasound.
Okay, fine.
So here the linea you can see here. So this trocar, why I marked here, in case of eat up groin, we use this as a telescopic trocar.
Okay.
But here we are going to do this
Okay.
subumbilical approach. conventional method for P-TEP, that is Pallivelsar technique.
Okay.
You can see the distance between the pubic symphysis here to the umbilicus. Ideally, we need a 15 centimeters to go freely to walk around. But in this case, I am getting only 12 centimeter as you can see.
Okay.
But even if it is 10 centimeter, but we can able to manage the space. The idea of this triangulation that is devised by Pallivelsar is mainly to handle both the side of the hernia from the head end. No need to change the monitors and everything. Just stand on one side and do the dissection. So we are going to start now.
Just a minute, Bharat. Is this trocar on the left side a bit medial to one on the right side? Is there any change in the trocar 5 trocar placement?
No, sir, it's in the same line.
Same line. The distance is also same from the
Same.
umbilicus. Okay.
That's what. Subumbilical trocar. The lateral border of the rectus is the marking for your right side trocar and also for the left side trocar. You are
Fine.
not supposed to go beyond the seminal line, but you can't able to do it. So that's why the space will be limited between the seminal line. That is the RS space.
Okay.
We are going to utilize the space.
Okay. Thank you.
Light. Lap. So you can see from the submit of the umbilicus, I am going to open this like this. You are not supposed to do like this. Sometimes you will open the peritoneum. So open the umbilicus, create the space like this. So make a 1 to 1.5 centimeter incision. For a beginner, I always use this incision because you can able to see the things clearly. Monopolar ஒன்று எடுத்துக்கங்க. கால்கிட்ட டயத்திரமே வைங்க. So even a small bleeding, I try to just stop it here because the field will be clear to show the anterior rectus sheath. So you can see this retractor here. You can able to see the retractor, sir?
Yeah.
This is a long blade retractor which is devised by a chief, sir. Particularly, you can see it is not a Langenbach. It is a modified retractor, so it has a long blade, so that even in obese patients, you can able to retract the rectus muscle peacefully.
We already have such retractors. We bought from
Yes,
Mexico.
sir. Yes, sir. So first, we are going to open the scarpa, camper and scarpa. Once you dissect it, you can see the retraction, how I am holding it. Top light. I made this big incision for you to visualize things clearly.
Okay.
You can see here, this is an anterior rectus sheath.
Yeah.
Top light. I am seeing the anterior rectus sheath. I am incising the anterior rectus sheath.
Yes.
Go near. You can see here, sir. This is the anterior rectus sheath.
Yeah.
I am incising it. What you see is the muscle.
Okay.
Retract the muscle laterally. Take all the muscles laterally, because if you leave something in between, it will be tough. And for the beginners, try to open the rectus incision, that is anterior rectus sheath incision, little away from the midline. Not exactly on the center of the midline, but because you will enter directly inside. So what you are going to see is the posterior rectus sheath. Go inside. This is the posterior rectus sheath. So retract all the muscles, create the space, and insert your first trocar. You can see the trocar, it is beveled edge, beveled cut. It is easy for the entry. Don't enter the trocar too much inside. Don't push the trocar. Basically, the trocar has to enter beyond the anti-rector sheath, that's just 1 centimeter. If you push too much inside, it will be trouble already in the limited space. So like this, ask your assistant to hold. Then whatever the defect we created, try to close it to avoid the air leakage. We are using a silk to approximate the defect area. So pack it with the wet gauze. So this is the time the trocar is in place. I'm connecting the gas, but I'm not going to switch it on. I'm keeping the pressure at high flow with 12 of pressure, it is more than enough. Don't go beyond 12 because sometimes emphysema will come if you push too much of gas inside. Recording scope, the scope is okay. So I'm using a 10 mm here.
Okay.
You can see here, sir, once we enter inside, what we are seeing the belly of the rectus muscle here. Below there is a rectus fascia, and that below is the posterior rectus sheath.
Yeah.
Now I am going to switch on the gas. It is not going freely. The trocar is very bad head. So now you can see I am just started the gas. Trocar is heating. Gas on பண்ணல. Gas பின்னாடி connect பண்ணல முதல்ல. பண்ணலன்னா மறுபடியும் செக் பண்ணுங்க. வரல எடுத்துட்டு மறுபடியும் மாட்டுங்க. Start. So once you put the gas, the plane will open like this. You can see. So take all the tissues up from the posterior rectus sheath. Clean. Head உள்ளார போதான்னு பார்க்கணும்லம்மா. You can see, sir.
Yeah.
What you are seeing is the posterior rectus sheath, and this is the posterior rectus fascia above.
Okay.
So with the telescope itself, we are going to create the space like this. Go and touch, take the tissues up. Clean it. The movement has to be slow and steady, to and fro movements. You are not supposed to do everywhere. See, because of the limited space. We know the rectus distance between the pubic symphysis and the umbilicus is less than 15 centimeter. So we need to gain the space in every centimeter is important for us.
Okay.
You can see here, take the tissues slowly, laterally. A balloon also can be used in this scenario, but the balloon is quite costly. Moreover, the fascias below the arcuate is always multilaminated. These multifaceted fascias, when you use a balloon, everything will coalesce together. So finding the right plane will be tough. Transversalis fascia is your road. So the road has to be clean. Take all the tissues up. That is the concept.
Okay.
So now you can see here that you can see the posterior rectus sheath.
Clearly.
Then slowly it comes down and ends at the arcuate, and what you are seeing is the transversalis fascia. Slowly we are breaching down. Because it is an irreducible hernia, you can able to see the contents here, indirect.
Okay.
Now the next step will be putting up the right side trocar. So slowly I am going to create the space here.
sir. If you encounter bleeding at this stage, how to tackle, sir?
Nothing to panic. Just take a gas inside. Just with the telescope itself, just give a compression over that area. Try to access the trocar as early as possible. Then you can use a bipolar.
Okay.
So now you get the outside view, please. First with the outside view. And the so now you can able to see the light here,
Yes.
because I am going to push the telescope against the lateral wall. That is the right lateral wall. You can see the light sign here.
Yes.
To avoid the injury to the posterior rectus sheath or the posterior peritoneum or the transversalis fascia, what you are going to see, I am keeping the telescope as a shield. Then I am going to put the trocar. Once we go inside, we will touch the telescope, not the posterior rectus sheath, to avoid the injury to the posterior rectus sheath and avoid the early pneumoperitoneum. I am using this technique. Ask your assistant to push like this, mark the area where you want to put. Head and down. Now I am going to the head end of the sides, head end of the patient. You can see the screwing motion. Even I am giving so much of pressure, I am touching only the scope, not the posterior rectus sheath. This is a simple technique what you use here to avoid the injury to the peritoneum. Now you can see I have entered without injuring it. This is one way to avoid the injury to the, otherwise when you push it down here, no, you can see the lap view there, it will injure. If you injure here, what you encounter is the pneumo here. Then handling the pneumo is tough initially. Clean. Height increase pannunga, head up pannunga, head down pannunga.
Dr. Bharat, I'm
Yes, sir.
curious about that length of the trocar. Are you using a bariatric trocar there?
No, sir. Regular one.
Regular one?
Regular one.
Okay.
The idea is not to push the trocar too much inside. I always keep the trocar just 1 centimeter or 1.5 centimeter from the skin level, depends upon the thickness of the patient. Because if you keep it like this, the torque will be reduced. The movement of the trocar, you can 360 degree you can utilize. Avoid angling of the trocar inside. Center, when you push it perpendicularly, enter inside, the movement of the trocar is very good.
Okay.
So now you hear, ma, suction mattu. டக்குன்னு எடுத்து வைக்கணும்லம்மா ரெக்கார்டிங் கேஸ்க்கு. சிசர்ஸ் எடுத்துங்க, இல்லை ஹூ கட் குடிங்கம்மா, எதுவுமே உள்ளர போகலம்மா. ஐ நெவர் எக்ஸ்பெக்டட். குடிம்மா. Hook. So the initial entry we made, the 2 trocars. Now we are going to create the space. I am using a hook monopolar here. You can use a scissors also. As we told already, you can see the multiple small perforators, what we are seeing here. When you go in the right plane, the bleeding will be less. Gas எடுத்துடுங்க. Now the crossing over of the midline, lower midline crossover. Gas எடுத்துடுங்க. Direct. Look like direct. Infinity gas இங்க இருக்கு, indirect. So the main cornerstone in case of a totally extraperitoneal repair is to create the space. Both TEP and TAPP has a good outcome. According to the literature, both are good. But we adopted this TEP technique because of some advantages. Because you are not supposed to enter into the abdomen, first thing. No need for peritoneal closures. You can use the harmonic or whatever the energy sources judicially here, because you are not going to injure the bowel. And moreover, it can be done regionally also when you're doing extraperitoneal repairs. And even in cirrhotic patients, we are doing a TEP repairs to avoid entering into the abdomen.
Okay.
And there is no need for peritoneal closure also, the port closures. That can avoid complication. The port site hernias will not be there. And the last advantage, because it's a teaching institution, we used to teach our PGs in the extraperitoneal area. They can use the diathermy initially judiciously without injuring anything.
But then, as far as step is concerned, Dr. Bharat, there are so many ways of putting a port. Like some people prefer to go in the midline. Why do you
Yes,
prefer
sir.
to go for this sort of card placement? What is the advantage of
Yes,
this?
sir. Agreed. Sir, basically the midline, what you're going to see here, Pasupati, outside view, please. I'll explain in just 2 minutes, sir.
Yeah.
So you can see here, there are two ways of approach. That's what I told you already while I starting the case.
Yeah.
The midline approach and the conventional P-TEP approach.
Yeah.
P-TEP is divided by Palnivelli, sir. Initially, Duluc and McKernan in 1980s itself, they have started the midline trocar approach only. Because what you're going to see at the short space, they used to put the true trocars in the line.
Yeah.
It will not support the ergonomics of the laparoscopy. Basically, the azimuth angle and the manipulation angle will be lost. And the triangulation also will be lost. Because the trocar will be here, the camera trocar.
Yeah.
And another consecutive two trocars will be here and here.
Yeah.
So approaching a large direct hernia with this trocar close near to this defect area is very tough.
Okay.
So that's why Palnivelli sir was not comfortable in the early 90s and the 91 itself.
Okay. Okay.
In 93, he devised a technique, new technique, enter into the retrospect like a triangulation. How we approached a TAPP.
Okay.
We could have wondered the TAPP could have been done in the same way like a midline approach, but they are not. It is done only in the triangulation approach, a TAPP.
Yeah.
The same way he adopted a technique in
Right.
TEP also. That is
Yeah.
more popular now. That's what people are nowadays using the ETEP groin approach because it
Okay.
is easy to learn.
Yeah. We are doing TEP in this technique only. Palnivelli
Yes, sir.
technique only.
Yes, sir. That will be very easy.
Much easier.
He
Yeah.
Yes, sir. He already made a road. We have to just drive safely. That is the only thing we have to do. The only tedious approach here is the crossover. You need some time to get the crossover. So each and every time you have to clean to avoid the fogging. Then you have to avoid the bleeding to gain the space. So after seeing the bone, so you can see able to see the bone here, sir.
Yeah. Yeah. Yeah.
So we are going to give the crossover. There are people who is telling that 10 golden rules for TEP. There are papers which can tell how to do the first step, second step and third step and all. The main purpose in TEP is to create the space and to identify the right plane. There are zones of dissection. In TAPP, what they used to tell, the zone 1 dissection first, that is a lateral to the inferior epigastric, the dissection has to be done. But in case of TEP, the zone 2 dissection, that is here, the space of Regius has to be done.
Right.
So what is the significance of the Duluc's fascia, sir?
So Dulux usually covers lateral to the inferior epigastric in the space of Bogros. It covers these named nerves. Lateral cutaneous nerve, that is ilioinguinal nerve, and gentle branch of the nerve, gentle branch, both femoral and gentle branches. When you breach the Duluc fascia, you will be injuring the nerves. That will produce a chronic pain to the patient. To avoid that, we will not breach the dewlux. That I will show you in the consecutive dissections. You can see already we made a injury to the peritoneum here.
Yes.
But the space can be managed. Don't worry about the injury. Even if there is injury, when you are in the right plane, 3 mm trocar. Because consecutively, I always explain how to make an injury, how to correct the injury.
Okay.
Even there is a pneumoperitoneum, don't worry, don't convert early to TAPP. Just wait. There are multiple ways to handle the pneumoperitoneum. You can see now because of the pneumo, my space is limited here. You can see the rent here.
Yes.
Yeah.
Okay, how we are going to handle the rent? That is the next thing. When you dissected the space of Bogros and Retzius, even the pneumoperitoneum will not hinder your dissection. That's what article says. That's what we believe also. So before creating the space of Bogros, if you have injury, definitely the field will be restricted because of the insufflation of the gas. But already we gained some space. There is a 3 mm trocar technique, what we use to handle the pneumoperitoneum. That I will tell you now. 3 mm. Lab இது காமிக்கிறீங்களா? Sir, can you able to see here?
Yeah, very well.
In case of pneumo, we are using this right side mid clavicular line, exactly just below the 12th rib. Mark it with 4 millimeter of incision, because if you put a 3 mm of incision, you have to push too much of pressure inside. So make widely the incision, that you can see the 3 mm trocar to let out the gas. Just push slowly inside. That's it. This will drain the gas. You can see. Now you can get the space immediately. You have to.
Yeah, fine. But as said, the left subcostal space is supposed to be the safest place,
Safest
normal
entry.
point. But why do you prefer a right subcostal space?
Sir, usually because we used to stand on the right side of the patient, we always prefer this. Because
Oh,
we are, you can see my cameraman is on the left side.
Okay, fine.
See, the idea is to put this trocar just below the 12th rib, because the one end will be fixed. The 12th rib will be fixed area. The other end will be pliable inside. So it is safe. We got to measure the length of the device which is going entering inside also. It has to be safely inserted. So
Okay.
now you can see the space here. So the furthermore rectus space, the midline crossover has done. The patient is quite fatty, but it doesn't looks like to be. You can see the posterior rectus sheath here, sir, on the left side. You can able to visualize here. This is the rectus muscle on the posterior rectus sheath. Clean, ma. The idea is to the trocar has to enter at the level. But in case of doing a right inguinal hernia alone, you can see the left side posterior rectus sheath here. Cut the left side posterior rectus sheath and enter into the retrorectus plane. You can see the arcuate on the left side, sir.
Yes, sir.
This is the arcuate. I am focusing now. So our trocar has to enter at the level of the arcuate on the opposite side. That is the concept. So you will have enough space to handle both the sides hernias. But in this case, the hernia is on only one side. So I may put the trocar a little bit down also. Good, ma. So with the left hand, I am using the left trocar, perpendicularly pushing the trocar inside and Once you breach the anterior rectus sheath, you can make the trocar oblique and enter here. You can see, get the inside view like
Yes.
this at the level of the arcuate. Gas maathunga. So now the zone 2 dissection is over. That is your space of Regius. Now we are going to approach the space of Bogros. Because the zone 2 and zone 1 dissection has to be finished before entering into the zone 3.
Yes.
That is your targeted area. In this case, the hernia was irreducible. Even though if it is irreducible, we do TEP in all the scenarios. But ideally for the beginners, a TAPP is good in case of a irreducible hernia. Now you can appreciate, ma hook kuduma. Illa Merlan kudu, hook kudu, edavunu kudu, Merlan kudu. We are using only 0 till now. Gas romba eduthu vidadinga. Inge glass close panni. Milling close. So you can see the hernia content.
Yes.
You can see the inferior epigastric here. This is the gonia. This is the inferior epigastric.
Okay.
It is barely visible because of the fat. You can see here. I don't want to explore this area. You can see the inferior epigastric.
Yes, sir.
So the content is just lateral to the inferior epigastric. So it is an indirect. This area is free. There is no hernia here. See, because of the too much of pad of fat, we are not able to see the bone clearly.
Okay.
You can see the bone here. So now we are going to approach here first. First create the lateral space. Just try to open it like this. You can see the peritoneal part of the sac.
Yes.
Now take all the tissues laterally. That is your first step. Because the dissection has to start from laterally. So it will be easy to identify the anatomy and the sling fibers. Take every precautions not to injure the vessels, because once it is bleedy, then it will be always bleedy. The extraperitoneal space always coats with blood, then identifying the anatomy will be tough. Now you can see the targeted area. This is our targeted area.
Yes.
This is the dewlux.
Yeah.
What you
Okay.
asked for, this is the dewlux fascia.
Yes. Thank
You are not supposed to go in this plane. You can see I am dissecting and showing you. See, when you dissect here, you can able to see the muscle here. You are not supposed to do this.
Okay.
Leave the pad of fat here. That's why the dissection has to start from laterally to take everything laterally where it belongs. Though this pad of fat will cover the named nerves.
Okay.
Otherwise, the postoperative consequences, the patient will come regularly to you. Pain, pain, pain. You can see here, this is the transversalis fascia attachment to the linea seminoralis. You can see some part of the muscle fibers here. We are going to dismantle this to gain the space of Bogros. Hookma. You should create this space carefully here. Usually you won't be able to see any muscle fibers here. Because of long-standing hernia, sometimes it will be there. The space creation has to occur simultaneously with the traction. You can see the left hand is very, very dominant, has to be dominant while doing a TEP or any laparoscopic surgeries. When the left hand is not dominant, it is very tough to handle the scenarios. Okay. Now the space is delineated nicely. up to the ASIS. You can see this is the ASIS, what I am pressing. Up to the ASIS, it is more than enough. But we always create extra 2-3 centimeters to accommodate a larger mesh. Clean. So with completing the zone 2 and zone 1 dissection, now we are going to see how to reduce the content of the sac. Till now I am using only the 0 degree, because 0 degree will be easy for the assistant to show. You can see the content here,
Yes.
and you can see the sling fibers here. We are going to damage the sling fibers. Once you damage the sling fibers, the content will fall down easily. In case of larger hernias, diagnosing the sling fibers is very tough. You can see the sling fibers here. These are small sling fibers which makes an hinge-cock mechanism. It will goes and winds around the deep ring. Even if you open the sac, don't worry. We can able to reduce the content. Amma, now you give the pressure outside. Now it's the time to try to reduce the content. You can see the movement here.
Yes, sir.
You can see the content is partially it is reduced. So with the consecutive pressure, the momentum is reduced partially. In some of the content is still there, but we'll hope it will be reduced. You can see something is still there.
Yes.
Now you can see, appreciate here, because we created the space here, there is enough space for the content to come down. Now the content has come down. Now it will be like a regular T. In case if you are not able to reduce the content here, what we do, we'll open the incision, we'll make an incision over the sac. We'll lay open, then we'll reduce the contents, then we'll push it inside. That's what we do in TEP. Now you can appreciate here the sling fibers. Because of the fat, the anatomy is little bit altered, but I'll tell you. So slowly take out the contents towards the indirect side. You can see this is the sac.
Yes.
You can give a traction. Once you damage the sling, the slack will fall onto your hand. Always identify the scrotal layers. Never try to pull the scrotal layers. This will lead to failure. Only the sac you have to dissect from the cord structures and not the vice versa. You can see,
Yes.
just slowly you just apply the pressure. Our idea is to complete the sac at any cost. We don't usually leave the sac. But there are trends nowadays to abandon the sac. Even in the 10 MIS golden rules, what they mention, leave the sac inside the scrotum itself. But we don't believe abandoning the sac. Even if it is open, don't worry. Identify the plane correctly, zoom, correcta focus panna. Pranav, maybe you can wear some glasses and buy me some glasses also. So you can see the traction, level of traction. You can see the vessels. The vessels will always come here. So the dissection has to start from laterally and to anteriorly. When you go medially only, you will injure the vas. So try to stick it here itself.
Dr. Bharat,
Yes, sir.
as we keep watching you, can you switch
Yes.
out other side and come back for a few minutes?
Please, please, sir.
Thank you so much.
Yes, sir.
Hello. Sendil sir. Good morning, sir. I'm Dr. Rakesh. Am I audible? Am I audible, sir? Good morning, sir. Greetings from Thoothukudi Medical College. We have a former professor, Professor Vasan sir, with us, and around 40 people watching you. Can you?
Actually, the proposal so actually the requirements of the outside for thank you.
cleaning room.
What is still maintenance? And this is still is a mix repeated episodes of this management and analytics and we get what's going to be shown linear results and math sentence so see this function PPLC responded individual program from indicators and C stops. PPLC used to get recurrent symptoms, so we have decided to go for distance multiplication. This also mainly is a patient, the patient has got isolated injury, like there would be linear ulcers, and if you are able to document isolated injury, and if the patient has got classical symptoms, the classical symptoms of GRD is retrosternal burning and rehabilitation. These two are the classical symptoms of gastroesophageal reflux disease. So if the patient has got classical symptoms of GRD and then the patient is responding to program from inhibitors, and we able to start people if he gets CRD gets recurrent symptoms, these patients can be managed well by this anti-reflux procedure. And you should we should sense sometimes if you do fundamentalization, the chance for recurrence will be slightly more, so avoid these patients. So this patient is an ideal patient. You can see there is you can appreciate the highest is right. You can appreciate this OT junction is here, and you can see the highest here. This is the highest which is white. So,
Sir, can you have a look at your port placement, sir, please?
So, I can show the ports. I will show from the microscopic camera. As you can see, different. So, you can appreciate. So, the microscopic sensor. Okay. We can say both this one. So, okay, so you can say this is the operators.
Yes, sir.
And just
Okay, sir. Okay, sir. Okay.
And this is the passport that they will before insulation we have got the passport market. And this is the which is
Yeah.
down. Right in this one.
And the second purpose, this is the working force. This is continuous working force of harmonic and radio and other measurements. This is how the overacts transfer voltage. Somewhere in the network program. So before insulation, working was very good. After insulation, the transfer voltage is not. This is above 90. So this instrument channels us below the 90 level. And this is a better electron. This is the electron 24. And this is the medium number electron. So this is the electron 24. And this every morning in progress. And you know, it's a connect thing. Electron 24. This is made into a electron. So that we can raise the awareness ACD. So these two are working instrument. This is one kind this is the last one. So this is a vector, this is made into a vector, this is after our copy content, this is different.
Okay, sir.
And even differential what we can appreciate from this is again our body family. So this is the vector, which is called previously not which is called and this appears and move. So whenever we use around 22 centimeters of the body family, we will be so that it will go inside. And we have to
ஒன்றும் பண்ண
And
மாட்டேன்.
from the back, this is okay, and
That's good actually.
this is again a 5 minute ball. So this is a standard one slide. So this is sorry. I don't want to play with me, and the Samuel is anesthetic and Chitra and somebody are assisting. So whenever I am doing any surgery, you have to confront the stomach. So here we can see this instrument. I'll put it in say. So I will take it out. This is a connection grammar screw. You can see it is coming on the left packet transfer. Then the instrument angle can angle the left packet transfer and see it is at the level of so we are done. We are very clear. You need to place your instrument very carefully because if you place it at the level of instrument will come into your operating field. So you have to put it as far as possible. So that you can nicely lift the left
மைக்கை
leg.
கரெக்ட் பண்ணுங்க.
So after lifting the left leg and
ஒரு எவ்வளோ கரெக்ட் பண்ணாலும் அந்த மைக் லெவல்ஸ் மாட்டிட்டு மைக் அது அவ்வளோதான். அவரும் கரெக்ட் பண்ணுறாரு. நான் அங்கே அது ஆனந்த டீம் ஹாஸ்பிட்டலே உள்ள பஸ் அவங்க ஆடியோ ஆடியோ நார்மலாக கரெக்ட் அப்படின்னு நம்ம ஆடியோ அவங்க ஆடியோ மைக் சொல்லிட்டேன் நான் அட்ஜஸ்ட் பண்றேன். அவுட்புட்டே அப்படின்னா
This is the transfer packet. You can see the transparent pin that is the
வாசனை கீழே இறங்கியிருக்கும். இது வாஸ் புரியுதா? சாக்கு நல்லா அட்டு வேண்டாம். இதெல்லாம் ஸ்லிங் கிருமா ஸ்லிங். விவசாயம் பிடிச்சிட்டு இருந்தேன். விசில் எங்கே இருக்கு?
Hello, sir. Yeah. Yeah, very nice, sir. Perfect.
So we are in the sense lab. Okay. Now we can see the anatomy. This is the right crus. So this is the right crus. Okay. And if you go and read, this is the IUC. Okay, this is the inferior vena cava here. This is cardiac flow, and this is the right crus. So, sister gives a diagram and lateral connection to the control. So once it is done, then you hold the crus. And try to enter a plane between the crus and the esophagus. traction. So I'm giving a traction to request immediately and system is giving random traction to the stomach. I'm giving random traction to the stomach, she is giving traction to the esophagus. Like that. So this is the plane. Make sure that you are not
அதை
splitting
ஏதோ
the
ஸ்பேர் பண்ண போய்
oviparous.
மாட்டிக்கணும். ரொம்ப திக்காக இருக்குல்ல, அது யூஸ்வலாக நம்ம என்ன பண்ணோம், அதில் போய் விசில் மாட்டிக்கும். முன்னாடியே கட் பண்ணி ஒரு சின்ன போர்ஷனை மட்டும் விட்டாச்சு, அவ்வளோதான். எவ்வளோ பிளாஸ்டடாக இருக்குது.
So this is the plane between the
முதல்ல சொல்லி தான் நல்ல கேஸாக பிடிச்சி வச்சுருப்பேன்.
esophagus and the rhinitis.
எனக்கு சொன்னப்பன்னு தெரியல. அவ்வளோதான்.
Okay, so you can see the beautiful plane. I'm giving I'm giving a good traction on the medial side. And you should come and identify the confluence of right and left crust here. And then also if you go down below, you have to confront the left transient pressure and celiac axis. So I can see now this is the confluence of right and left crust.
Yes, sir.
Posterior valgus, this is posterior valgus, this is esophagus, this is televersity number.
ராசிங்காக தான் இருக்குது.
The put your instrument inside and do traction. So just what you have to do is just lift the esophagus like this. Okay, just lift the esophagus. Slide your instrument around the left. Slide your instrument around the left in the proper plane. And this freeriserial membrane will come into it. Whatever is the membrane, this is the freeriserial membrane. Just divide it across 360 degree.
So have you placed a Rayleigh tube in the esophagus, sir? Do you need that?
After they are going to rotate first, because we have some confusing for most factors. So just for you because
Okay, sir.
so cardiac was incision and anterior posture. Anterior has to be very careful because valgus now will be coming. Here you can see this is the attachment of stomach to the diaphragm. That is the area of the stomach, bad area of stomach.
அங்கே என்ன ஆச்சுன்னு தெரியல, சீஃப் பண்ண கேஸு முடிச்சாரா? கெதிட்டர் போட்டிருக்கீங்க, கெதிட்டர் ஒன்றும் ட்ரைனாக வர மாதிரி தெரியல.
Introduce your instrument. This is the face here. So you do it like this. Protect your esophagus with the
கால் கிட்ட திரும்பி.
So do it like this. The esophagus with anterior valgus will go down. And do nice traction with your left hand. So you can see the anterior valgus will be running on the sections of the esophagus.
க்ளூ பண்ண ரெடி பண்ணிட்டியா?
Here is something that have the inferior phrenic vessel. This is a area where you get the inferior phrenic vessel. You have to be very careful. If you are not happy, then you go from below. So that is the esophagus coming into view. Okay. I am again going from behind. So putting my left hand instrument, lifting it, sliding the instrument along the opposite. So you can see here. So this is the cross. This is the cerebral membrane to divide it.
என்னடா டே காசு ஒன்று எடுத்துக்கிறியா ஸ்பெஷல் காசு சும்மா ஒரு ஸ்பெஷல் காசு கொடு அங்கங்கே மாப் பண்ணி வைப்போம் லாஸ்ட்டாக 5 mm போட்டு இது வழியாக எடுத்துக்கோ சீஃப் என்ன ஸ்டேட்டஸ் மாமா அங்கே என்ன பண்ணுறாரு முடிச்சிட்டாரா பரவாயில்ல பிஜிசி யாருமா இருக்கிறது வெளில அது சிம்பிளாக தான் இருந்திருக்கும் பட் இருந்தாலும் யங் ஏஜு கஞ்சனிட்டலாக இருக்கும் சம்டைம்ஸு அது கஞ்சனிட்டல் சிஸ்டம் வந்து நம்ம போய் இதுவே லிம்பாட்டிக்கை ட்ரங்க் இருந்துச்சா பார்த்தாரான்னு எனக்கு ஒன்றும் புரியல டீ பாஸுங்க மியூட் பண்ணியிருக்கீங்களா
So that we can give a better traction to the east side, so that we can do a better mid-axis rotation. So this pole has come inside. So give nice traction here.
Sandil sir. As we keep watching you, can you switch over to the other side and come back? Yeah. Thank you. Somebody will be watching you. Thank you, sir. Hello,
Hello, sir.
Dr. Bharat. Yeah, we are with you. We
Yes,
kept
sir.
watching your sac dissection and
Yes,
demonstrating
sir.
your. Oh, yeah,
Yes, sir. Can you see completely the sac has been out.
yeah.
So
Those,
we always have a tendency to take out completely sac. We don't abandon the sac. So we removed everything completely. You can see the vase here, and you can see the vessel here.
yeah,
You can see the triangle.
yeah,
This is the triangle of doom. You can see the external iliac and artery and vein. Sir, can you able to see here?
yeah, yeah. Very clearly.
பசுபதி அங்கே போலையாட்டிருக்கு.
Clearly. No, you are able to see.
போதா?
Dr. Bharat.
Hello?
Yeah, yeah. The clarity is very good. We are able to see whatever you are showing.
Sir, can you able to hear me?
Yeah, yeah. I can hear you. Can you hear me?
Yes, sir. Yes, sir. Sir, this is a dissected sac. What
Yeah.
you are seeing here, that has been completely removed.
Yeah.
We always loop at the base here.
Tighten the sac or what? You'll just leave it like this.
Yeah, we always leave the sac like this, sir. We don't excise. If we
Okay.
excise, we need another 10 mm trigger to take it out.
Okay.
So we always
Oh,
put a
there's
loop
no
and leave the
particular
sac as it is.
inside.
It will
There is
not
no
produce any harm.
Pardon?
And what you are seeing is the triangle. This is a vase, medially, laterally, the vessels, and the reflected peritoneum down. This forms a triangle of doom. You can see the vessels here,
Yeah, we can.
external artery, vein. So you
Yeah.
have to be careful here. And when you go near, there are three ways to stop the medial dissection. One is the turning of the vase.
Yeah.
The other one is the median umbilical ligament. You can see the medial umbilical. This is the median umbilical ligament here. And when you go down, this is the obturator.
Okay.
So beyond this, the level of dissection should not be encouraged. Otherwise, you will injure the retropubic components. The bleeding of this retropubic area, it is very difficult to control.
Okay.
So you can see the Hasselbalch's triangle. Because of the fat, I am not able to delineate the boundaries here. The rectus muscle, inferior epigastric, and the pubic bone here, the
Yeah.
Coopers. They are going to keep the mesh here and fix it. The dissected area, I am going to show you now. Just go inside. You can see the completely dissected area.
Yeah, yeah. Very good.
Clean again. So the laterally, up to the ASIS we are done. So inferiorly, from the indirect ring, almost more than 7 centimeter we have dissected to accommodate a breadth that is 12 into 18 centimeter of a mesh. You can see the level of dissection down, and you
Yeah.
can see in the all the way of dissection we have preserved this dulux. We are not injured the dulux in any way.
Yeah.
So now the next step is looping the sac and keeping it drained. So
Okay.
keeping it drained, there are two schools of thought. Some people used to say no need for drain. But in case of indirect hernia, we have a tendency to keep the drain. So it reduces the postoperative seroma. Even if you remove the sac, in case of indirect hernia, keeping it drain will avoid the seroma for 48 hours. So 48 hours you have to keep the drain.
Okay.
So now I will tell you how to loop the sac. So we are
So
using
do
a
you always
cathet here.
do a bilateral repair for even for a unilateral hernia in a TEP?
Sir,
Do you always do a bilateral repair for even if it's a unilateral hernia, or you prefer
no
to do
sir,
it
in this case it is an indirect. So we are not supposed to do the left side dissection. But in case of the patient is more than 50 years and is having a direct hernia, we always do the simultaneous repairs. It depends
Okay.
upon the age and weakness of the muscles. But moreover, the counseling to the patient is the first priority, because sometimes they will not accept it, doing both the repairs.
Okay.
So the clinical repair always the first primary thing to do.
Okay.
So careful should be taken here not to take any abdominal structures in the loop. So the sac should be hooked up like this to apply the loop. This is the catgut. The memory will be very good. Hold it. In case of a large hernias, these sacs we always try to dissect it and take it out.
Okay.
So like this, if you keep it out, you keep a mesh here, the sac will oppose the mesh like this. Drain ma.
No, will not there be a seroma collection within this occluded sac? Was my question.
No, sir. Usually that's what. We haven't noticed till now. Post-operatively, the patient comes for follow-up in case of a large hernias. Sometimes we used to do ultrasounds. We never encountered such things. That
Okay.
will usually gets obliterated. And moreover, when you take the sac, there will be some injuries here in the this sac area. The
That will-
seroma, even if it is there, it will be get absorbed. You can see, sir.
Yeah.
Some rent is there.
Okay.
So this rent will not allow the formation of a hydrocele.
Okay.
How to choose a area for the drain? That is the next thing. You can see, palpate the ASIS. Just go above, like here. Avoid going onto the dulux. So whenever you put the drain, carefully, not perpendicularly in this scenario, outside view. Don't put any drain perpendicularly in TEP, because the angulation, when the drain goes inside into the groin area, that will produce an angulation that will alter the placement of the mesh. So what I am doing here, obliquely along the muscle fibers, like this, we have to do it. So when you keep a drain, the drain has to closely along the muscle fibers. That's the idea.
Yeah, that's a very good practical point. Thank you.
Yes, sir. Usually the drain will go along with the muscle. That is, parallelly the drain will be placed. Slow. So guide the drain into the area. Come out. We always keep a suction drain. No open drain is advocated here. Only closed drains. Okay, enough. Take it out. So now you can see the drain will go and just place parallel to the muscle. Otherwise, the drain, if you do perpendicularly, the drain will stay like this.
Yeah,
You
understood.
can't keep a mesh. That's why
Understood.
you are placing it like this.
Good.
Mesh, please. Mesh லைட்டாக கட் பண்ணிக்கம்மா கொஞ்சம், ரொம்ப பெருசு வேண்டாம், மினிமலாக. So even the article literature says the 10 MIS repair, 10 golden rules. What they are advocating, the more the size of the mesh, less the recurrence. But the standard size is 10 into 15 centimeter. That's what SAGE's guideline says. A 10 into 15 centimeter of mesh in the dissected area is more than enough. But as a routine practice in gym, we always keep a quite larger mesh, that is a 12 into 18 centimeter mesh. We specifically design and ask for the moderate weight with minimal pores. That's what we use a Prolene mesh regularly here. So whenever we use a mesh, we always fix the mesh. But the literature says when you do a TEP repair, when you keep a mesh, no need for fixation. But we don't agree with that point, because taking a single bite is more than enough. You can get a nice peaceful sleep in the night. We have encountered 2-3 cases where we didn't fix the mesh is migrated to the medially or laterally. That has produced a recurrence. We have done 3 cases like this. The patient has been done elsewhere outside. In TEP, they have not fixed the mesh, but because of these recurrence, we always keep a point to fix the mesh in the Coopers. There are 3 ways of fixation. Clean and go inside. Cleaning கொடுத்துருங்க. So even though the literature says there is no need for fixation, there are other schools who teach us to fix the mesh always. One is at the level of the Coopers. Here, we always fix it here. The other thing is just above your pubic symphysis, here. And the laterally above the IPT, this here. Above the IPT, you can keep the mesh fixed here. And always in the midline, sometimes you can fix it. In case of a large direct hernias, we advocate multiple sutures to fix the mesh medially, not a single bite, to avoid the recurrences. Sometimes in case of direct hernias, we can't be able to keep the drain. So what we do, we used to plicate the direct area to give a proper roof for the mesh to imbibe. So always in case of direct, plicate the sac to avoid the dead space, to avoid the seroma, and always fix the mesh medially. Make sure your mesh always crosses the midline and cover the opposite area at least 2 centimeter in case of a direct hernia, but not in case of indirect. We always keep at the level of the midline. That is what we are going to show now. Outside view, Pasupati. You can see while preparing the mesh, sister has changed the glove. She has used this glove paper. I am not going to touch. Without touch technique, we used to take the mesh inside. See here, I am just sketching it here. Once it is entered, see I am not touching the mesh. No need to suture the mesh like a banana leaf. You just roll the mesh and take it inside like this. Take it inside and push it inside. That's it. The mesh will be onto your dissected area. So you will have enough space to handle the mesh. Clean. Okay. Once you enter, you can able to visualize things like this. This is the medial area. You can see the marked uncut area. This area is not cut. This shows medial upper border. So take the mesh horizontally and play in the dissected area in the center. The center of the mesh will be in the indirect area. That is the concept. Like this. Like this. So in the center. So what you do now, just open the mesh. That's it. Roof kaamikkanga. We're not supposed to show the roof. Floor. Floor. So like this, when you do a proper fertilization medially, you can see the mesh will be tucked inside. Like this. This is how a mesh should sit in the dissected area. Now the mesh has been set nicely here. So this is what in TEP they will tell no need for fixation. But even though with the driving force we have encountered, as I mentioned already, we have encountered 3-4 cases like that the mesh is migrated onto the opposite side and rolled. That's why we always keep the mesh and fix it here. Because in case of a recurrence, a medial is always common. That's why fixing the mesh onto the Cooper's single bite is mandatory from our practice. Can you able to see, sir? The mesh is nicely placed without any wrinkles. Hello?
Yeah, clearly, Dr. Bharat.
Yes, sir.
Dr. Bharat, what's your experience of adherent cecum in case of a TEP?
Sir?
In case the cecum lies very close to the peritoneum, no? There, in the right iliac fossa.
Yes, sir. In case of, that's what, sir. In case of sliding hernias, we expected the bowel to be a part of the sac. And in case of right side, even in the left side hernias, we used to encounter sigmoid. Sometimes it will be loaded up here. That time doing a fertilization here on the left side will be very tough. So you have to go slowly to avoid injury to the sigmoid. The same concept here on the right side, sometimes cecum will be pulled up little bit. So in case of previous appendectomy open scars, we used to expect some difficulty here in creating the space of Bogros.
Oh.
So we used to go slowly, sir. That is the only thing. Not to injure anything, go extra peritoneally. Even if there is injury, try to identify it early.
Okay.
That is the main concept. So the idea of coverage of the mesh, you can be able to see from the Coopers up to 3 centimeters. It has covered. You can see the obturator area is covered, the femoral area is covered, the direct area is covered, and the indirect area, the drain is going inside. by all the areas have been covered. The myopectoral orifice of Fruchard is entirely bombarded and just plastered by this mesh so that the recurrence will not be there in the future.
Okay.
Hopefully.
Would you like to have a look into the peritoneum before you remove the right subcostal trocar? Do
Yes,
you
sir,
routinely do
definitely,
that?
sir. After placing the mesh, under the vision, we used to deflate the gas. Then we used to put the gas inside into the abdomen. Then
Okay.
we'll see the trocar, whether it caused any injury or not. Then only we remove it. This is our routine practice. Because
Okay.
blindly we inserted the trocar. So
Okay.
ideally it has to be seen.
Right.
Mesh fixation.
So that
This
was
is
a
the
wonderful
final.
demonstration, Dr. Bharat. I'll
Thank
ask
you,
if
thank you,
any
sir.
questions from the audience.
Sure,
Questions
sir.
from the audience? Yeah. I have Dr. Simona Pandian, Dr. Raj Kumar from Tirunelveli Medical College and their team. We have my
Yes, sir,
former
please.
professor, Dr. Professor Vasan sir, with us,
Yes,
all
sir.
eminent faculty. So Vasan sir, any questions? We have a pediatric surgeon, Venkata Saravan sir. Sir, would you like to ask something about pediatric hernias? Dr. Bharat is very senior laparoscopic surgeon in GEM, very well versed with laparoscopy. Like to have anything? Dr. Bharat, as we watched you suturing, can you switch over to the opposite side and come back for the next case?
Please, sir. Please, sir.
Thank you so much. That was a
Yes,
wonderful
sir. Thank you.
demonstration. Thank you, Bharat.
Thank
Can
you,
you
sir.
give
Thank you.
an applause for Dr. Bharat, please?
It's my pleasure, sir.
Thank you,
Thank
Dr.
you.
Bharat. Thank you. We'll
Thank
come
you to
back
be a
again.
part of this program.
Thank you. Thank you.
Yes.
Sendil, sir. Yeah, we
Pashupati
are
ji.
with you, sir. We are watching you dissecting the short gastrics and suturing the crura. Can you explain what has been happening all these times, sir? Yeah.
And we are completely different from we can appreciate right is exposed. And so if you reduce average attachment, probably about retrogressive or posterior artery will become a the posterior part of the magnus of the stomach. But let's say if you reduce it, you know, completely reverse very nicely from the left side to right side. So that there will not be any pressure on the ground. And that's a tail which is lying close to your instrument. Bring it out on the set, so automatically the graph will get expired. It will get arranged by the knot. And this is just approximation, there's nothing. You know, see. So just approximate the program. And this approximate the throat muscles, it has got a good strength. Sometimes if it is really the throat muscles have it is very thin. The main thing is not to preserve the structure of the should be preserved. You should not open this page. If you open this page, the person will go the machine control will get split and it can transfer these variations. So you make sure that you have resolved the primary fibers. Previously, when temperature was open, we used to introduce the Fuji inside and do Fuji. But with the experience, you know, much of today, so this, you just leave this responses and access. I think this is enough. So if you put responses, you can have sticks on and there's a matter of this area. So you now here looking at the space now, put down to the media so it should translate program. So this is what I already can have this here. So give some space. It's not only the next one which is going inside. And if you relax, transfer, if you look at you just relax it, see, it gets nicely. Because we have finished this already. I think this should be enough.
Yes, sir.
And now I'm going to bring the so now you have to do you have to bring it and this one so this is the this is right here. This is the posterior artery and posterior artery and right is here. And keep the reservoir like this. Stay from the reservoir like this. Here, and so this is the anterior of the fundus, and this is the posterior of the fundus. So feeling like this class is not like this, but so this is anterior, this is posterior, this is parallel. So if I go this side, two side maneuver, and I put this in the divergent front axis. This is anterior, this is posterior. Okay.
Okay, sir.
Now I will be doing control that. So I'm taking one stitch here and onto the esophagus and onto the fundus on this side. Down the navel. Take one bite again.
So is there any criteria to decide on whether you do a 180 or a 360-degree wrap, sir?
Unless things are good, mostly we prefer to do 360 degree multiplication. For a 360 degree distance multiplication. Sometimes the person has not some multiplication that is what we do. And we cannot very happily use as a promoted anti-reflex procedure. When we use the analysis when there is a mucosal injury following LS. So just come outside. So following you, sometimes the is any mucosal injury following spinal paralysis, we close the. We close the mucosal effect and we cover it with the maternal wrap, which is gas anterior rapidly using. Otherwise, we normally prefer to use 360-degree distance front application.
Okay.
And, so, if you look at currently, also how to access the flatness of the RAM. Previously, when the program was introduced, they used to do at 20 centimeters from the RAM. The RAM used to be 5 centimeters in length. Now it is 2 centimeters. We use 2 centimeters of the relation. 2 centimeters from the RAM for sort of it will not cause any. Unfortunately, if it is too So this is the first part. The mountain base 2 to 3 inches. You can use any control functions. Sometimes you can use echelon suture. You can use 2-0 echelon stitch. So now what you can do is you trace over the instrument. So this is the campus access for me. This is the esophagus. So you see how this is the esophagus and the campus. So this is the body. And here this side also. Now when I take this edge, bring it here and go slightly on the left side, away from the edge. So if you do one the object you will find a fixation again. So make sure that you are making the base away from the edges of the stomach which is coming across. So again, this is a zero. So introduce put your instrument. So put your instrument like this and the left hand instrument. Just go first and the thread is a bit short. So you can hold the needle also. So first and second. Sometimes you can use the curved also. If the thread is very short, you can use the curved this one. Catch it, and you can see that knot becomes automatically square, it becomes a square knot. So this I can appreciate for 45-degree angle spot with the very clear part which is placed well above the umbilicus and also under the left of the umbilicus, not on the in the midline. Helps in identifying the left cross and also it helps in dividing actually the area where it helps is the division of the sarcastic vessel. The exposure will be very good if you place the board on the left side of the midline and at least 6-7 centimeters above the umbilicus. And if it is available, you can use 45 degree, but you can manage it with 30 degree telescope. I'm taking this needle out. So the second needle is inside. Actually, this is it has got two needles. This term has got two needles. So you can divide it into two. One, only one is enough. Sometimes we use. Again, you have to reach it. Please. So again, you can see there is a good space between the esophagus and the pancreas. And therefore, I'm going for a clear structure which I will place it close. See, again, my main point is not take a bite here, try to come and take a bite here. And this side also, go and take bite away from the edge. In this one. In this one. So this is it. See no button. So go around, pick like this. Actually, this thread is difficult to handle. And after that, you form a reverse C. This is called the reverse C. When you form a reverse C, keep the right hand on the right hand, use the left hand to grab it. Catch the thread. Again, form a C. Grab it with the right hand. Catch it. So automatically, the knot gets squared. You get a square knot. So, we have done the fundal application. Now we will fix it to the program. See the fundal. See the laxity. Fundal bracket is very large and it is above the knot which we have placed. It is actually falling on the esophagus. So you should not do a fundal wrap or a family that can cause post-operative regurgitation. They will have difficulty in swallowing, regurgitation, everything. So you should make sure that the fundal wrap falls on the esophagus. So I take a bite to the pleura, this esophageal membrane and part of the pleura. Relax. So I take a bite so that this will prevent the fundal wrap from migrating into the mediastinum. A good stitch to the esophageal membrane helps in preventing transmigration of the entire wrap into the mediastinum. and fix it to the screw. Again, you have to keep the iron, which is just behind in mind before taking this bite.
Sendil sir, how do you choose the cases for a fundo, sir? What are the investigations you do in your institution?
It's based on disease. So what people have the patients will be managed by medical management. The patient is given and the patient has severe symptoms. Severe disadvantages, hypertrophy, patients who are responding to put on my BPU and if they respond well to BPU, so the patient says that after 3 months, after the BPA effect, the last one of the previous year, I start in the BPA. After 3-4 days, if the patient gets symptoms again, and if you feel that these injuries severe, then you can offer profile physical therapy or condition, which is microscopic distance publication. Then we go for local publication. Sometimes if you have potential dose, if you physical translation disease, and there is no recognition injury, like disease. Then we have to go, this identifier things monitoring. To prove that this person has not been reflex program. That was
So in case there is a esophageal injury, we can directly take up the patient with an OGD itself, sir. No need for a pH monitoring or a emanometry. Thank you, sir. That was a totally bloodless, wonderful surgery, sir. It was a wonderful demonstration. So, Thank you. Thank you very much, sir. That was a totally wonderful bloodless surgery. Thank you for the wonderful demonstration. Thank you, sir. You can hear the applause from the audience. We are nearly 40-50 people around Somalia. Thank you so much, sir. As we get ready for the next case, we'll switch over to the other side and come back again, sir. Thank you. Thank you, sir. Hello? Dr.
Good morning.
Harish?
Yeah, Dr. Harish here. Can you hear?
Yeah, sure. I am Dr. Rakesh from
Yes,
the
sir.
Department of General Surgery. Greetings. Good morning.
Nice to speak to you, sir. Like I told yesterday, I'm really sorry that some of our major cases they're advanced disease, so we are not able to post them. But alternatively, what we have planned right now, I'll be showing a short video, about 20-25 minutes video of D3 lymphodectomy of for right hemicolectomy. And after the next case, in between that one, I will be showing one anterior section, that is about 40 minutes video as an alternate to live video. Okay. So first I will be starting with laparoscopic right hemicolectomy, that is CVL CME D3. So what is the concept of right hemicolectomy? Now there is a kind of slight difference of thoughts in between West and the East. In Japan, mostly they concentrate on D3 lymphodectomy. What they do there is go to the vascular pedicle and clear off all the lymph nodes from there. But whereas East and Western side, they follow the concept of CME with CVL. What they do here is complete mesocolic excision along with central vascular ligation. What we do is something very similar. There are many ways of approaching right hemicolectomy. One is that starting from medial, from the vascular first and then going laterally. There are people who start from hepatic flexure, that is superior down approach. But what we follow, what is called as an IRITA approach. What is IRITA? Is an initial retrocolic endoscopic tunneling approach. What we are going to do is go into the told fascia in the beginning itself from below, from the caudal area. And then we are going to create a tunnel and completely separate the mesocolon from the retroperitoneum. And then our dissection will again proceed from medial to lateral. It is basically again a medial to lateral approach only, but before that, what we do is we separate the colon and the mesocolon from the retroperitoneum. This was first started in 2005-6 only we have started this one, but published around 2016 after a certain number of cases. Today this approach is also called as caudal cranial approach by some surgeons, but basically it's the same thing as IRITA approach. So what we do here, this is the port positions what we put. The first position is the camera, suprapubic camera. This camera helps in dissection for the IRITA approach, that is a caudal to cranial approach for separating the told fascia. We use this camera. Once this camera, once the work is done, then the camera for the second half of the surgery, that is the dissection of the hepatocolic hepatic flexure, we shift the camera to umbilicus. So when we go to umbilicus camera 2, this is the area of dissection that is covered. The right iliac fossa port, what we have put is for the right iliac and the left iliac fossa. These are the main working ports, and the one in the left hypochondrium, that is the traction port. This port can be placed in the left hypochondrium as well as epigastrum, whichever is convenient. It is not going to make significant difference. These are traction ports. So D3 lymphodectomy, when they are doing, they go to the vascular pedicle and complete all the nodes from that pedicle is completely cleared. So that is when complete clearance is obtained. So terminologies, like I said, they are slightly different from each other, but basically it's a mesocolic excision and complete removal of lymph nodes. CME requires proximal vascular ligation, but they don't specify where you have to go and clip at the origin of the feeding vessels or slightly distal to that. That is not very clearly specified. But whereas D3, it specified that you have to go to the vascular pedicle and clear all the lymph nodes from there. So what we do is basically completely clear the vascular pedicle, all the nodes from there, as well as complete mesocolic excision. So I'll show you the technique of how we do that one. Now the patient, like I said, the ports have been placed in position, and then we have lifted from the umbilical port, we have lifted the mesentery here, and the traction port is given traction to the cecum here. So we are going to release the peritoneum below. As we release the peritoneum, the told fascia is seen here. See, the stoled fascia is present throughout the colon, from the ileocecal junction and through the transverse colon up to the rectum. The what we go in the TMA plane, it's the same stoled fascia which is continuing there. So this is the avascular plane, and in this plane where we continue the dissection. This stoled fascia has two interfaces, one which is attached towards the mesocolon, that is mesocolic interface, and one which is towards the retroperitoneum, that is retrofacial interface. So what we are going to do is push the mesofacial interface downwards. You should not dissect and from the close to the gerotas and then push it upward. You should not do in that direction, because you are going to breach the gerota and you are going to injure that one. See, like what we are doing here, we are going to cut the Toll's fascia and then push it downwards. So that is the best way to dissect the Toll's fascia. So as we come medially, now you are seeing slowly that D3 is coming into visibility. You take a gauze and slightly give traction to the mesentery and go anterior to the duodenum. So give the traction, the mesentery is pulled up, and in that the fibers are cut. Slowly duodenum is come into the visibility. Below you can see the gerotas fascia, which I am pushing it downwards now. Here important thing is when the patient is, the BMI is more than 35, generally the fascia is well formed and easy to dissect. If the patient BMI is lower, say about 18 or 20, then the fascia is not well formed, very difficult to differentiate the Toll's fascia from the mesocolon fascia. Sometimes small breaches will be there in the mesocolon. So first what I am doing here, separating all the Toll's fascia and separating the mesocolon from the retroperitoneum. Again I am dissecting close to the duodenum now. As we dissect this fascia, then slowly the pancreas will come into visibility here. You can use scissors also and do this, mostly a avascular plane. You can use harmonic with a slightly fast mode, it nicely cuts the tissue, so you can cut and then push the duodenum away. In this plane, if you go superiorly here, I will go up to the D1. If we continue superiorly again from the same plane, it will go under the transverse colon and open into the hepatic flexure. So most of the time when we do, we go up till the hepatic flexure from here, and if it's feasible, we open up the hepatic flexure, or we can dissect till there, then we can go shift the camera to umbilicus and then do the hepatic flexure dissection from above. Now you see the T2 portion, you can see the this one, the pancreas also visible. Now once that is done, we keep a gauze over that, so that will protect the duodenum later. So now we are given a traction to the ileocecal junction and to the middle colic pedicle, and we have seen a bowstringing effect is there. So from there, see the pulsation, 5 centimeters you come distally, laterally, and then start dissecting. Once, because we have already opened the fascia, the plane behind, but the moment we cut this mesentery, we get the rent. So we can just follow. We have seen the pulsation, and accordingly we have cut the peritoneum above and marked in which direction we are going to do the dissection. So I am going and searching for ileocolic vein now. Ileocolic vein or artery. Most of the time, vein will be on the lateral side and artery will be on the medial side. There are very few variations. About 1 to 2% of the cases only we will find the artery on the medial side, but most of the cases it is a vein which you are going to encounter first. So once we identify the vein, then you go to the adventitia of the vein and start dissecting. You will start getting the plane. Sometimes in a very fatty patient, what will happen, the paniculitis will be there and you may not be able to separate completely. So you can leave that and then do the dissection. So now initially I am searching for the vein. Now see, now this small vessel is visible now. So I am going to search for that where it is going. You see, I told you, paniculitis, sometimes it may not be able to separate completely. Now you see the vein has come. You can see the superior SMV coming into the picture there, and this is the ileocolic pedicle. Ileocolic pedicle is almost always there, almost 100% of the time it is there, very rarely it is absent. See, these ileocolic pedicles, artery and vein position may be slightly different. Sometimes the artery will be going under the vein and coming, or sometimes it will be over the vein. So you need to slightly dissect and identify which location it is coming, identify both the artery and the vein, dissect individually and then clip individually. So my dissection is going right now very close to the SMV and ileocolic pedicle junction, so that all the nodes and the tissues are separated and pushed medially towards the specimen. So the complete vessel is bared of all the tissues. So before I clip, what I do, I look for the direction in which the vein is going, SMV is going, because once it is cut, then it is difficult to hold the vessel and then give the traction. So at this point, once you identify the artery, you look for superior right colic artery, because there is a small chance that right colic artery may start from ileocolic artery. Very small percentages is there. So once we know it is possible, then you have to search for it and then clear the rest of the tissue. So I'm still searching for the vein to identify which direction the vein is going. So slowly I'm clearing all the lymph nodal tissue from there. Once I identify, then I clip both of them individually. You can use a regular metal clip or a hemolog. So both of them are cut. Now as I ascend superiorly, now I am looking for if any right colic vein artery is there. Right colic artery, it is there only about 45 to 50% of the time. So statistics will slightly vary, but not significant from each other. Most of the time it will be around this area, about a few centimeters below the pancreatic head. Sometimes it may arise from the middle colic right branch, it can arise from the middle colic trunk, it can arise from the ileocolic vessel also, it can arise. So you have to be very careful when dissecting and looking for right colic. So as we proceed superiorly, in this case we couldn't find the right colic. So as we proceed superiorly along the vein, now one more small vein is coming into the visibility here. So now we need to identify, there are few veins come and join at this point. That is called as a gastrocolic trunk. That is a gastroepiploic vein, right colic vein, middle colic vein. All these come and join together here. So these veins, what happens is it may come and join individually, or some two veins may join together and form a short trunk, or there can be a long trunk. So what we generally do is first identify each of these veins, see how the formation is, and then go and clip it. Sometimes if there too much of fat is there, of course you can clip and then proceed, there is nothing wrong in that, but where possible identify all the branches and then clipping is better. Now see, there is a gastroepiploic branch is coming from below. To the right of my instrument is a middle colic, and right here to left of my instrument, what you are seeing here is the right colic vein. Right colic vein here, sometimes a pancreatic branch will come. See, a small pancreatic branch has come and joined the right colic vein here. So individually dissect all of them and then decide how you want to clip them. See, in tumors of cecum, not necessary to do complete D3 dissection at the middle colic vessel, because chances of spread are very, very low. It is somewhere between 0 to 2.4%. So if you can skip also, there is nothing wrong. See, this is the main final trunk. You can see the middle colic vein, superior mesenteric vein, gastro. You can see gastrocolic trunk is very short here. So it will be slightly different to each cases. Now once gastrocolic middle colic vein is seen, just lateral to that, most of the time middle colic trunk will be there. So once you identify the trunk, you have to trace it superiorly towards the mesentery and see where the branching is. Sometimes there will be very short trunk will be there, which is extremely short, less than 1 centimeter. Most of the cases it is between 1 to 3 centimeters. But sometimes the individual branches come and open into superior mesenteric artery. So you need to identify both the branches, in which direction the branch is going, identify right and left, and only then you have to clip, depending on you are doing a right hemicolectomy or extended right hemicolectomy. If you are going for extended, you are going to take the trunk out. If you are right, means you are going to cut only the right branch and spare the left branch. This is a middle colic vein I am cutting right now and dissecting the middle colic artery. You can see the middle colic trunk is there to the right of my instrument. So all the lymph nodal tissue I am clearing from here. So you can use bipolar, it's a very good instrument. When you get small vessel bleed, you can immediately cauterize there and then continue the dissection, or you can use like this suction. It will also give a nice, it is nice to push away all the fatty tissue from there. So you see there is a pretty long trunk here. So I am searching for the right and the left branch. Once I identify both the branch, then I will have to decide which branch to cut. So left branch, right has been identified, left is slowly coming into view. Now you can see where I am dissecting, there is a left branch there. Left branch of the middle colic. So left branch, all the adipovascular tissue I am clearing around that one. So that is the right and the left branches, middle colic trunk, and below is the superior mesenteric artery. So once that is done, then once I am clear that these two are the branches, circumferentially dissect the vessel and then clip and cut it. So now what we have done after this is we have slowly moved away from extracorporeal anastomosis to intracorporeal anastomosis over last 1 to 1.5 years. Today all our right hemicolectomies what we are doing is intracorporeal anastomosis. So we know that it's a benefit to the patient, definitely a benefit to the patient. Return to bowel function, passing of first flatus and ileus is all reduced in intracorporeal anastomosis. So this is the right branch which I am clipping right now. So because that space was not there, I had to create some space before clipping the that right colic branch. I am clearing all the lymph nodal tissue. This is the pancreas. Over the head of the pancreas I am clearing the attachments now. As we proceed superiorly, we will go to the D1. So once we get adequate clearance from here, then we need to see on the bowel which direction we have to go. We need to, what we do is we hold one bowel holding forceps to the point, and from towards that point we cut and go towards the bowel. This is all the pancreatic attachments we are releasing, separating. So see, now you can see the complete dissection is done. I am searching for the bowel there, where to hold. This is where I have clipped the right branch. See, from right branch towards the bowel I am going to go and clear all the vessels. Clear all the mesocolon. So again, at this time traction is very important. One person has to hold the traction here. Even when we are dissecting near the middle colic pedicle, we need to have a lateral traction there. Sometimes we may get a doubt how we identify middle colic from the right colic. When you give a lateral traction, if it is a middle colic vessel, they generally tend to go upwards, whereas if it is a right colic, they go perpendicular to the main vessel towards the right. So that's how we identify whether it's middle colic branch or right colic branch. Sometimes they will be very close and difficult to identify. This is a rough guide you can use. So I'm clearing all the mesentery and going towards the bowel. So I need to clear the bowel circumferentially now. All the tissues and the vessels I have to clear, so that if you are going to apply the stapler. Here ligashure or harmonic, both you can use, both are excellent instruments for using. Now see, the bowel wall has come there. So I am clearing all of them, and circumferentially I am going to make the bowel nude so that I can apply the stapler later on. So once we do this later in the step, you can see how nicely the line of demarcation develops here. Either you can see the line of demarcation, or alternatively you can use an ICG and see the line of demarcation. Now coming to the hepatic flexure. See, now already we have done the dissection aorta, we have done it from below. See, now the hepatic flexure is almost completely dissected. All I have to do is go and release this tissue. One gauze is always kept on the duodenum, and once this procedure from aorta is done, what we do is we keep one gauze at the first part of the duodenum. We push it and keep. So see, there you can see the gauze below. I kept at the first part of the duodenum there. So when I am coming from here, that will give me a guidance and which direction to go. These beautiful techniques developed by our chief, no, Dr. Palnivelu, he's been doing for so many years. See, now completely it's cleared. Now I am preparing the colon for anastomosis. See, now it's completely cleared. Circumferentially I have cleared the colon here. This is the point of anastomosis I will be doing. So whatever leftover tissue, you clear it off now. Don't anastomosis very far away from the edge of the mesentery. That is when the leaks will happen. So wherever you cut the mesentery, make sure that your anastomotic stapler is right next to the mesentery. So that's how you will be avoiding an anastomotic leak. That's a very important step. So now I am coming towards the ileum. 10 centimeters I have to remove the ileum. Here see I have used the ligature instrument. You can use harmonic. So this is done. See now what we do is there are two ways of anastomosis at this point of time. One anastomosis we transect colon and transect ileum. Separately we anastomose in the isoperistaltic fashion. This is in antiperistaltic fashion, the same way which we do in open surgery. If you see now, you can see the line of demarcation developed in both colon and ileum where I am taking the suture, just proximal to the sutures. So I am going to take a stay suture now and keep both the bowel adjacent to each other. Most of the time what we do is isoperistaltic, that is we transect both colon and ileum, and later we put one stapler and anastomose this. What I have slightly trying out a different technique of the same peristalsis. Here we will not have to suture the defect, we can directly finish with one extra stapler. You can do both, there is nothing wrong in both. We have got excellent results in both of them. This is a 13 mm port I have inserted in the right iliac fossa. In the initial cases we used two 13 mm, but now we have adapted the technique, and with only one 13 mm in the right iliac fossa we can apply both the staplers. This is a blue load we have taken. So I am going to pass the stapler into both of them. Make sure that there are no bowel underneath that when you are doing this one. Make the hole just adjacent to the your tinea, so that the tinea can come as a part of the anastomosis. So first stapler is fired. Because it's a short stapler, what I am going to do is I am going to apply another stapler through this and make the long anastomosis. This is a second way of doing the anastomosis. The first way I told you, transect everything and then put one stapler and suture the defect. This is another way where you don't require suturing of the defect. You can directly apply the stapler like the open fashion we do. So the second stapler, now we can see the wide anastomosis is there. So it will not make any difference whether you are doing antiperistaltic or isoperistaltic, because anastomosis is quite wide now. Once it is done, a T anastomosis, transaction is done and the bowel is separated now. Make sure that the entire defect comes to this side of the stapler line. In very thick individuals, sometimes two stapler will be required. At times only one is enough for transaction. So once it is done, there will be some oozing will be there. Sometimes intracorporeal bleed will be there post stapler. So what we do is generally overrun with a PDS. This is the same procedure what we do in open also when we do. This is a 2-0 PDS and overrunning the anastomosis. See, because we are not pulling and pushing the mesentery when we do open, what happens, we pull the entire intestine outside, this tugging on the mesentery. That generally results in slightly delayed bowel functions. But if you see with respect to anastomotic leaks, complications and all, intracorporeal, extracorporeal, both are almost identical. It's not one is significantly better than the other. But when it comes to recovery of bowel functions, patient performance, all those things, intracorporeal is far better, because I'll be putting a peninsula incision. The pain is also reduced for the patient. It is comfortable. Recurrent hernia is also reduced. The chances are much less in the peninsula incision. So once it is done, we put a peninsula incision and remove the specimen. The last part to release is the lateral attachment. I'll leave the lateral attachment till the end until I finish the anastomosis, because it itself will hold the colon in place and not allow it to roll around when I'm doing the anastomotic part. Now you see the complete mesocolic and D3 lymphadenectomy has been done here. And we place a drain under this. Slowly, one by one, complete clearance has been done. This is the specimen. Thank you.
Thank you, Dr. Harish. That was a wonderful demonstration.
Thank you, sir.
Any questions from the audience? We have postgraduates who are coming from Tirunelveli Medical College, as well as we have postgraduates here. They're all here. We just ask them if they have got any questions. Ms. Marsuk, Agilan, final years, if you have any questions, you can ask them about hemicolectomy, CVL, CME, anything. PGs from Tirunelveli, any questions you can ask them. So as it keeps going, we'll ask some questions.
Sure, sir.
Thank you, Dr. Harish. What are we going to do next?
Pardon me, sir?
What's next for us?
I think it's a fundoplication. I will just confirm and tell, sir. Most
Yeah.
likely, I think it's a fundoplication.
Okay.
Thank you.
Thank you. Thank you so much.
Right, sir. Thank you.
Hello. Okay. Tap or tap, sir? Okay, sir. We saw a TED demonstration of GEM today morning. So we'll have a look at tap also, sir. Hello. Hello, are you audible there? Yeah, good morning. Yeah, good morning, Rich.
Thank you, sir, for the opportunity. Thanks, sir, also giving this opportunity to understand. So, this is a case of 23-year-old patient. So, the time is right in front of the study. Last 1 year, it was gradually increasing. The last few days, 15 days, he has pain in the right body.
Why did you prefer a tap for this patient instead of a tap? How did you choose tap over tap for this patient?
It was asked for tap actually.
Oh, that's for the demonstration purpose. Okay. What would your preference be? Tap or tap?
So usually, so in fever patient we prefer tap. In labs, importance prefer attack to get the physical incarcerated. When it feel like in the server, either when you can plan a promote, there are multiple problems which are stuck inside. When they in those cases, we choose for PFP.
Okay. Otherwise, your general preference for uncomplicated hernias will be tap. Am I right?
Yes, sir. We
Oh.
started with actually when we joined here, the people used to do only PET and private cases.
Okay.
But then as we are trying some of the demonstration purpose that any training here, we used to teach them PET first.
Okay.
But we started PET.
Okay.
So this is a case of right-sided looks like indirect immunodermatology. And start the peripheral dissection. So as soon as you make the peritoneal incision, the pneumo gets into the pre-peritoneal space automatically, and the air on its own starts dissecting the plate. You have to be very careful to choose the place here so that you are away from the inferior digestive vessel. And just put in your instrument inside the rectal vein and extend the incision laterally. In first incision, you can even keep the, if the peritoneum looks very thick, you can keep the fascia transversalis reverse. So that the closure of the peritoneum, reflected peritoneum or peritoneal tract will be little easier, and there will be no rents while we close the flap. Of the picture quality is fine there, sir.
Yes, sir.
So very important here is the traction by the blood test, which will avoid any, especially for the beginners who are trying to do their first speech surgery, you must avoid injury to the inferior epigastric vessels, because that is one hurdle which will come as soon as you start the surgery. So first problem is the inferior epigastric vessel injury, which should be prevented, and for that we have to take incision either medially or laterally to start with. And second thing to remember is give good traction with the left hand here. Okay. So this is what traction I was talking about. See this traction, and don't work on the abdominal wall, rather than that you work over the peritoneum. Okay, and you would soon enter into the avascular plane. You divide the fascia transversalis so that you enter laterally into the for training purpose. That when we start with inguinal hernia pre-peritoneal dissection, we will get into the correct plane first and then divide, get the medial plane well and go in the same plane till you reach the like that. So here I am dividing the fascia transversalis to get exactly into the pre-peritoneal. Once you are into correct pre-peritoneal plane, you will see that bleeding is lesser because you achieve the avascular plane. Just follow this particular plane. You see, even without the bones of That time you can easily dissect here because there are no vessels. But small bouts of diaphragm will keep you relief in the sense that you are into hemostatic field, and when the field is without blood, the chances of losing the current plane is very less. So you can follow the avascular plane. Just slowly we get urinary bladder coming into the field below. Again, the pressure by the left hand is very important here. The abdominal wall is lifting above the structures which we do not want, and our left hand is giving a good traction so that we get into the correct plane. Postgraduates, when you start with this dissection can be done with various instruments, including Maryland, the diathermy, monopolar diathermy. It can be done with bipolar instrument if you are used to that more than the monopolar. This can be done with the hook instrument. And again, the pressure by the left hand has to be very tender so that you do not damage the organ which is coming below. Bladder in this particular case. On and off, small parts of diaphragm will help you managing the small bleeds, and that's how you keep your vision clear there. These smaller pushes will make your way clear. That's called as lighthouse sign. And we see the pubic symphysis there right of it, and the right pubic superior arch, which you see. So you have to be very careful again here because there are minor vessels over the bone. Sometimes the superior pubic ramus branch as well. So we take down the bladder with its fat, and left hand is pushing down the bladder, and I am in the avascular zone again between the bladder and the abdominal wall, getting into the retropubic space. So we have entered the regius here. This should be good, deep enough, because this will be the place where the mesh will be tucked in medially. In any case of hernia, that we have to go beyond at least 2 centimeters to the opposite side in case of unilateral hernias. So now you can appreciate that we have made it better. Okay. Medially we have taken down the bladder. We have got into the space of regions, which is retropubic here, and we can see the lighthouse sign which we could see a minutes before. This is pubic symphysis. That is almost 2 centimeters dissections on the opposite side, which will be extending a bit more little later. Once we are done with that, probably that we can enter into the lateral inguinal space and continue a dissection. Again, here the fat belongs to the abdominal wall, and and you have to leave it there. So only carry the peritoneum with you. Rest all other layers has to be divided and get into the correct pre-peritoneal space. There is plane getting above there, but that will lead you into a wrong pre-peritoneal plane. That's not exactly the right pre-peritoneal plane. And in that plane you will find that more number of vessels are communicating and chances of bleeding is more. And if you do not leave this fat and abdominal pelvic fascia over the nerves, the post-op may be little difficult for the patient in terms of the pain. So if you watch carefully, I am dividing a layer which allows this abdominal wall fat to be there over the nerves, the area of triangular pain which will be opening up soon. So this is our target area which is heating oil ring and heating oil ring and the radiator made a rector. Time, not a very large section which is not into my visual field.
Yeah,
So
beautifully.
I cannot picture anything which is behind, which is not seen. For example, this vessel belongs to the bladder, but divide it from
Yeah, understood, understood.
I follow only with the tip. And once you do a small dissection with the tip, probably you get enough good amount of dissection further. As possible, this study, that is not always recommended. You can divide the sac whenever you feel like you have enough environment to learn side as a mesh, rather than doing a complete dissection there. So, try to divide the fascia transversalis completely here. Once it moves above, can you appreciate the sling here?
Yeah, yeah, very well.
This fascia transversalis thing. So probably that, especially in indirect cases, you have to divide them well so that you can get along the indirect side. Would like to divide it here rather than going more above.
Is it not necessary to go around the sac before you divide this, Dr. Piyush?
No, we usually don't go around the side. So I will doing that now.
Okay.
So just follow the peritoneum like this.
Okay.
Just follow the peritoneum like this. Follow the peritoneum. Push away all other structures. And then the visible peritoneum can be divided like this. Again, the same maneuver. Same maneuver.
Yeah, very well.
When the same this is what I was talking about, the abdominal pelvic threshold, which is listening structure here, which is covering the nerves which are lying lateral to the gonadal vessels. And that has to be preserved and should not be damaged. So slowly again for postgraduate step now that we are opening up the triangle of the you see the mass which is intact with its own fascia and gonadal vessels are here and the triangle looks quite small here. Now we will be enlarging it. And this triangle which is you see the iliopubic tract here below this tract and lateral to the gonadal vessels, you see this triangle clearly which is covered by the now the anatomy is a bit more clear.
Yeah, very clear.
Yes, sir. This is what I was saying that we do not do circumferentially to the sac not always.
Yeah, this is a different technique which you have shown us. We'll learn a new technique today. Yeah.
Yes, sir. Because we keep these structures which belong to the pelvic wall on their original place rather than shifting them. Slowly keep going here and there would be a place where medial umbilical ligament would be crossing the vas and that becomes our inferior limit of dissection. So this is what I was trying to show that the important structure has to be given respect, swiped away slowly, and then you see fibers there that you can coagulate to move further on the dissection.
Dr. Piyush, that was a wonderful dissection. We are watching you. As we continue to watch you, can you go to the other side and come back?
Yes, sir, please, sir.
Thank
Piyush, sir. Hello.
Yeah, Dr. Sarana Kumar, good morning. I'm Dr. Rakesh. We are with you. Hello. Hello, Dr. Sarana Kumar. Sir. Hello. Am I audible?
பண்ணியிருக்கா ஹலோ
Hello. Hello,
ஹலோ
sir. Am I audible?
ஹலோ ஹலோ
Yeah, you're audible.
Okay, sir. Okay, right. Thank you, sir. Thank you for that opportunity. And this is, we are planning to do a lab fund application. I think Dr. Sendil would have been shown that Nissan's fund application. So I'll
Yeah.
show you how to do a two-pay fund application, 270 degree. Right, this patient GRD regurgitation with pre-op evaluation by endoscopy showing lax LES with grade 3 esophagitis along with 24 hours PH study showing more than 15, that is around 40 total score and with the demister score. With this one manometry showing there is no evidence of any pressure waves. So we are planning to do a routine standard 2-pay 270 degree fundoplication, sir. This is the abdomen. We can show that
Do
you
you
can able to see this
cases
one.
of fundoplication with all these 4 investigations, sir? Endoscopy, we are 24 hours
Endoscopy,
pH monitoring as well as
exactly.
24
Suppose
hours monitoring.
24 hours pH study and manometry is always mandatory for any sort of fund application we are planning. Suppose if
Okay.
the endoscopic findings is so evident of grade 3 to 4 esophagitis are associated like esophageal associated complications like short scaring or stricture, then we can straight away going with fund application without doing 24 hours pH study. Or otherwise, if we are having smallest doubt, patients having symptomatic GRD, endoscopy findings is not supportive, then we have to confirm with the 24 pH study, then we can plan for that one. Along with, we have to do a manometry, is not mandatory for all the patients, sir.
Okay, sir.
And this is the epigastric region, xiphisternum. This is the umbilicus. So, fundoplication always, I am planning to do a first trocar with the varus nemo. Usually, first 2/3, upper 2/3 and lower 1/3, exactly over here. From there, I am going to 1 to 2 centimeter away from the midline because most of the dissection in the OG junction as well as, and if I am going close to the midline, there is a chance of falciform hindering our dissection showing the camera. That's why I am going little bit away from that one. Can you see here? So I am going to place a, and by this is a varus needle technique, giving a, making a small dent like this way. That's all gone inside, and always with the 14 pressure mercury. Now it's inside. And always when you are placing that varus needle, it will allow only maximum of 1.5 to 2.5 liters per minute. So it shows that it is in the peritoneum, right? You can see, you can appreciate that distension of the abdomen. And during the percussion also, liver dullness obliterated. And I am going to use the 5 ports technique, standard 5 port techniques over here.
Are we having a rail tube in the esophagus, sir?
Yes, already we have placed the Rell's tube. Once I am gone inside, always any upper GI surgery, under vision, you have to empty the fundus, which is the reservoir of the stomach, where you can see most of the fluids or stages over there. So under vision, you have to complete you have to reduce the fluids or air inside after placing the trocars.
Okay, sir.
And here I am going to place a 10 mm for 30 degree telescope. So you can see a nice dome over here. In the summit, I am placing a 10 mm trocar. Gas matuma. Don't open the gas now. You have to go and see inside. Right? Gone inside. Now I have opened up the gas. Clean panicking. This is the leg splitting position. I asked them to make a reverse Trendelenburg position, header position. நல்லா பண்ணிக்குமா நல்லா பண்ணுங்க ஹைட் பண்ணிக்கங்க ஹைட் பண்ணிக்கங்க complete reverse Trendelenburg height பண்ணுங்க okay left up slightly okay right now see you can see here first I have inspected all over the abdomen and now I have to retract the liver. Either we can do a Nathan's retractor or we can place like routinely we are using see one 5 mm trocar with some instrument we can retract that one or sling technique we can use, right? I am going to use with this one. Hold panna. Gas. கொடுங்க மேலே வாங்க ஒரு ஆள் right just this is a Kumaran's needle holder just I am going to place this one from here just and at the end of the falciform just I am pushing the lever such a way that see it's nicely being retracted. This is more than sufficient, you can see here, right? No need of placing any, it all depends on experience, how much, whether, see I am not denying that Nathan's also can be used. This is our one way of retracting this one. See easily you can see the OG junction, nicely you can see a small hiatus hernia also, right? And the next trocar, this is the costal margin, right? Opposite to the greater curvature, right? This is my working trocar, right hand working trocar. And usually, see, there is no hard and fast rules of placing the trocars. All depends on the inside abdomen and the liver. And usually, mid-clavicular line. This is on the mid-clavicular line. Usually, on the just opposite the greater curvature. This is first working trocar. இதில் ஹார்மோனிக்கெலாம் நல்லா ஃப்ரீயாக போகுது செக் பண்ணிட்டீங்களா right you can see here, right? And another trocar for retraction, by the time you just take out that this one, see over here and the anterior axillary line for the retraction of the momentum by the stiffness. This is retraction port. வெளியில தெரியுதுல you can see, right? Suppose we are having any doubt regarding the surgery's technical tips, at any time you can stop me. I'll stop and I will discuss and move on.
Sure, sir.
Yes, sir. And this is my left hand working trocar, probably not too away close to the mid-clavicular line, just maybe 3 to 5 centimeter close to the midline. And because I am planning to come through the falciform over here, either it can come close. Okay, it shouldn't disturb my left hand working trocar with the liver retractor. That's why I am planning such a way that I am going little bit away, right? இங்கே எதை போட்டுக்க ஒரு பவுல் ஹோல்டிங் போடுங்க. See, now you can see my trocar is coming through the falciform, I am coming out. ரைட் யா இதில் போட்டுங்க. பவுல் ஹோல்டிங் இங்கே கொடுங்க. ரைட் ஸ்டெப் சக் பண்ண ரெடியா இருமா? ரைட் வெயிட் ஸ்லோ இல்லை, அவ்வளோ திக்கான பண்ண வேணாம், ஜஸ்ட் அப்படி ஹோல்ட் பண்ணிக்க போதும். நவ் பாரு, இதை மட்டும் அப்படி பிடிச்சிக்கோங்க, வேறு எதுவும் கான்சன்ட்ரேட் பண்ணாமல். ரைஸ் டியூபை ஜஸ்ட் உள்ளே புஷ் பண்ணுறீங்களா லைட்டாக? இல்லை வெளியில் இழுங்க ஒரு தடவை காமிங்க எங்கே இருக்குன்னு. See, we have to see the rails tube. Now I can able to see this one. இப்போ சக் பண்ணுங்க. I have placed in the fundus. பைப்போலார் கொடுப்பா. There is an instrument injury to the spleen, capsular injury. Gas கொடுத்துக்கங்க. gas கொடுங்க. gasமா better. This is not intentional, accidental, right?
Anyway, it's a bonus for us to know how to manage a splenic bleed, sir.
Clean பண்ணிக்கோ. That's why you have to be very careful while moving the instruments also. The small instrument tip causing the injury, we'll see. First try to apply the bipolar, don't try to keep on apply the bipolar. Then just give just compression over there, and because this is only capsular injury, suction கொடுத்துக்கோங்க மேல. We will leave it like that. If needed, we can apply some surgical, or we'll take it later. The one problem is our plane of dissection, that holy plane of dissection will be obscured over here. அது சக் பண்ண வேண்டாம், let it be there. பார்த்துக்கலாம், காசு இருக்கட்டும். சக்ஷன் போடுங்க. ஆம் சக் பண்ணுமா? வருதா ஒன்றும் இல்லை. சரி, ஓகே. எடுத்து 30 சென்டிமீட்டரில் வச்சுக்கோங்க. இது கொடுமா, லிகாஷர் கொடுங்க. ஹார்மோனிக். So I am going to start from the left side. இதை பிடிச்சுக்கோ. From the left crest, right? And here on the peritoneum, harmonic இருக்கா கால் பக்கத்துல? Right. Let me first try to expose the left crest over here. Here the traction and the counter traction along the fundus, I am giving a traction. So you can see a peritoneum over there, and along with that gastrophrenic attachments over here. Nicely started coming out. Don't give too much of traction on the left side, and slowly you have to go, and while applying the harmonic, I am relaxing my left hand. If you are noticing that one, that's most important. Otherwise, sudden release of that small vessels or short gastric can cause bleeding. So you can see that started coming out. Now we can see the left crest. This is the left crest.
On the left side of the stomach, where do you start the dissection, Dr. Saranakumar?
Sir, just I have started on the left crest, the peritoneum on the left crest. I have started coming down, and this is the first vessel. If needed, I can go ahead with the short gastric, and the first or second vessels sometimes can be.
Okay.
1 second. This is all because of small traction, right? Holding இருக்கா வேண்டாம் இது பண்ணிக்கலாம் இல்லாட்டி காசு வச்சுக்கலாம் இன்னொரு காசு எடுத்துக்கோங்க see this is the first vessel.
Yes.
I'm going there, right? While doing that one, I have relaxed my left hand. And slowly I have forward my dissection towards the posterior aspect now, gently. Right. கொடுங்க சக்ஷன் கொடுங்க ஒரு நிமிஷம் suck. So this is what I told you, say just to give a bipolar in the spleen, suppose not being settled down, just to give a, don't keep on trying with anything, just to give a traction. I mean, you have to relax your traction and give a gauge pressure over that, automatically it will settle down, right? Nice. And this is the posterior aspect of the fundus.
Should
Right?
we identify the vagus? Not needed.
No, no. Which one, sir?
Vagus, vagus.
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 Yeah. No, no, no. I am not gone into that one. I am showing the dissection. இங்கே படிங்க harmony கொண்டு வா. I am on the left side, left crest only. I am not gone into the Kushner's window. See, this is the posterior most, that is inferior aspect of the gastropancreatic, some sort of attachment close to the left crest. You can see a nice crest over here.
Yes.
See my dissection on the from the left side. I am not gone to the right side now. I will show you how, because most of the dissection I have done from the left side, ready for the tunneling, then I will go to the right side, then it will be easily, I can reach the tunnel with the blind end, right? Either way you can do that one, either you can start from right side to left or left to right, all depends on that one. I will show you from left to right how to go about the dissection, right? Yeah. Now I have done that one dissection. Let it be like that. Retraction இங்கே கொடுங்க அப்படி ரைட் ஸ்டிப் இழுத்து 30 சென்டிமீட்டர் வச்சாச்சுல்ல ரைட் அண்ட் see you can see this is the fundus, this is the OG junction. You can see a OG junction pad of fat over here, and just below the OG junction you have to just hold this one, give a traction like this way, and if you are giving a lateral traction you can see a nice Kushner's window over here started opening up, and I started entering into the, see, you can see a nice window over here, right? So just try to enter the There's a sac. Have entered now. So mostly avascular plane. So fast mode, I can boldly reach my inferior part of dissection up to left gastric vessels. See, you can see a left gastric nicely, go close, right? So you can see a left gastric nicely, and I'll open up all the
Sarakumar sir, as we watch you dissecting the right crest, shall we go to the other side and come back?
yes,
Just
sure, sir, sure,
yeah.
always. Right.
Thank you, sir.
I-
Yes, sir.
Hello, Dr. Piyush, we are with you.
இது படிமா
We saw you suturing the peritoneal defect. Yeah. Yeah.
படிச்சுக்கோ.
Yeah.
This is important. Okay. What shouldn't be happen நினைச்சோமோ அதான் ஆகுது.
Yeah.
இல்லை அது அது
No.
அது அன்னெசரி இல்லை அது அன்னெசரி ரிஸ்க் இல்லையா வீடு ஆகிட்டே இருந்ததுன்னு வச்சுக்கோ மண்டை
Yes, sir. Yeah, pubic symphysis.
கண்டிஸ்ட் ஆகிட்டா
Yeah. Right.
See, this is the white line. You can see this white line now. So this is important. Exactly அந்த white lineல போயிட்டு just above. இங்கே போகக்கூடாது. You have to go here. Just superior to the இங்கிட்டு போகணும்.
Yeah, clearly.
இது மெடிக்கல் காலேஜ் இந்த அசிஸ்டன்ட் ப்ரொஃபஸர்ஸ் பிஜிஸ்
Yeah.
See, this is the way.
Yeah.
See? Okay. Go close, little bit close. Yeah.
Yeah. Right.
அம்மா இங்கே வாப்பா மெதுவா ஃபாஸ்ட்டாக பண்ணக்கூடாது மெதுவாக ஜென்டில் மூமெண்ட் இருக்கணும்
Yeah. Yeah.
That's the posterior vagus. This is the posterior vagus. See, this is the already dissected much, you opened up. This is the advantage of doing section from left to right. See, window opening. So easy, no? Always will be, when you start dissecting this one, it will be in the இதில் தான் இருக்கும். ஓகே இதை பிடிச்சிக்கோ. So this is the anterior peritoneum.
Yeah, beautiful demonstration. Yeah.
This is the part of the peritoneal membrane. Go close. Yeah. இரு வச்சுக்கோ. ஓகே பிடிச்சிக்கோ. கம்.
Do you routinely coagulate the vessels in this area before you take a bite, Dr. Piyush? Is it recommended?
See, this is a pre-nasopharyngeal membrane. You can see here. See, this is the pre-nasopharyngeal. So we
Okay.
have to go layer by layer.
Okay.
And because anterior vagus will come somewhere here, but
Okay.
see, the pre-nasopharyngeal. பாருங்க நீ அப்படியே அப்படியே மெது அப்படியே வச்சுக்கோ, அப்படியே வச்சுக்கோ. கேஸ் ஃபுல்லாக எடுத்து விட்டுருக்கியான்னு பார்த்துக்கோ. கொஞ்சம் கம்மியாகவே எடுத்து விட்டுக்கோ.
Yeah.
Five fibers you have to go on this here. This is the free noise idea. See, this is the anterior vagus. Okay? This is the anterior vagus. So நம்ம என்ன பண்ணலாம்னா இதை அப்படியே வச்சுக்கலாம். Because otherwise they won't understand what we have done. இதான்
Yeah.
teaching us.
Very well.
Right? Yeah, அந்த லேயரை மட்டும் வச்சுக்கலாம். நம்ம will go ahead with that. இது பண்ணிக்கலாம்.
Yeah.
படிமா. Come. See? Posterior vagus, anterior vagus. இது வந்து pre-nasopharyngeal. See? Posterior vagus, anterior vagus, pre-nasopharyngeal membrane. And this is the anterior vagus. So we are able to divide. அதை அவங்ககிட்ட காமிச்சிக்கலாம். நம்ம என்ன பண்ணலாம்னா இது கொடுத்து எடுத்துட்டு இல்லை இது பண்ணி அம்பிக்கல் காட்டன் டேப்பு இன்னொரு காசு வேணா கொடுத்துரு காமிச்சிக்கலாம். இப்படி இந்த இடத்துல would have been washed up, no?
Yeah.
எடுத்து
So the transform medium pubis here, it is called as medium pubic flap. That goes down there and you
ஒரு செக்ஷன் கொடுத்துருங்க, அப்புறம் த்ரெட் கொடுத்துருங்க. செக்ஷன் போட்டு
Yeah, very well. Yeah, and covered by the fascia too, beautifully. Yeah.
ரெண்டு காசு இருக்கு. சரியா? இது கூட த்ரெட் கூட. படிச்சுக்கோ.
These nerves are of importance and the ocular nerve is shown here. See, this is the ocular nerve getting into the ocular foramen, ocular vessels, and the connection which is called as ocular vessel. Okay, can you see the communication here? This is the inferior epigastric.
அது விஷன் வந்து ஒரு மாதிரி டிஸ்டர்ப் பண்ணிட்டே இருக்கும். That's why
inferior epigastric and the ocular vessel. Or it may be anastomosis to the external.
Okay, இல்லை அதை நான் டிசைட் பண்ணல. ஜஸ்ட் ஐ அம் டூயிங் திஸ் ஒன்.
This originates from the ocular system itself.
இது கொடுத்துமா நீடில் ஹோல்டர் ஆல்வேஸ் நீடில் ஹோல்டர் ஃபார் நாட்டிங்.
Okay, and we have taken the bladder down everywhere here. We have preserved the bladder fat also, bladder vessels also, and again the fascia on the bladder. Can you appreciate that? The space of the chest is very open up quite well so that our flesh will go and take the here and to the opposite side of the centimeters of dissection has been carried out. And the inferior dissection should be well enough so that flesh does not get folded here and come to a border. If you want, you can keep one or two elements extra not this. So that mesh is not folded there.
என்னாச்சு? சரி, ஒரு நாட் போட்டுக்கிறேன், 2 நாட்டு வேண்டாம். சரி, ஓகே. எக்ஸாக்ட்லி என்ன பண்ணணும்னா, பண்ணிட்டு lift this one, see this one, see this is at the OG junction you have to place this one. That is important, at the OG junction, not too tight. Right?
This was my mistake that I have opened this particular design. Can I keep the brush inside, sir? You see the
Yeah. Yes, sir. Very well.
ஏம்மா த்ரெட்டாக வருது தெரியுதா? ஒருவேளை நான் கை பிடிக்கிறது சரியில்லையா, இல்லை த்ரெட்டு சரியில்லையா, இல்லை நீடில் ஹோல்டர் சரியில்லையான்னு தெரியல. சம்திங் ஏதோ ஒன்று, இல்லாட்டி என்னோட ஹேண்ட்ஸ் ரஃப் ஆயிடுச்சுன்னு நினைக்கிறேன். என்னோட ஹேண்ட்.
What is the size of the mesh you're using, sir?
This is 12 by 15 size mesh.
Okay.
Trust.
18 by 12 by 18 mesh, which is
This is standard now. Most of the people.
Yes.
Most of the people, they're happy with that. Yeah.
Being on one side is always constant, nothing less than that.
Because our dissection is always close to the this thing, no, that what do you call
And for larger direct defense,
arcuate line.
we can even go, we can even keep centimeters and go between, that is on the opposite side.
என்ன பண்ணலாம், அங்கே வர வரைக்கும் கீழே இதை டிசைட் பண்ணிட்டு அதை மட்டும் அப்புறம் பண்ணிட்டேன்.
Should have at least 2 to 3 centimeters, nothing less than that. This is the prostatic area which has been, the mesh has been divided a little bit here on the prostatic side.
Yeah.
Nice. The mesh is intact as a cable. Back.
இது கை.
So can you see how the edges get bent?
Sorry.
It's very clear.
Yeah.
So the very important thing is there should be no uneven point here.
ஓகே.
Yes, sir.
அப்புறம் கட் பண்ணிக்கலாம் சார்.
The interior cutting of the mesh should be good enough. You should get into
Ball
the
welding கொடுத்துருக்கோம்.
space well so that it does not move.
See, that's why what you have to do, இதை வந்து கொஞ்சம் இங்கே போட்டுக்கலாம். Yeah.
So rather than dividing the mesh,
அதெல்லாம் ஒன்றும் நான் ஒபிசிட்டி எப்பயுமே அப்படி தான் பண்ணிட்டு இருக்கேன்.
more space there.
Okay, sir.
இன்னொரு பவுல் வெல்டிங் கொடுத்துருங்க. இதெல்லாம் மொபிலைஸ் பண்ணி வச்சுக்கலாம்.
Dividing the meshes. And here also sometimes we have taken a point.
எனக்கு அவங்களுக்கு அந்த கரெக்டான அந்த ஸ்டெப் காமிக்கணும்னு நினைக்கிறேன். பட் இஃப் யூ டிலேயிங் டூ மச் தென்
Here centimeter 2 centimeters above. More dissection. Rather than now structure pulling
இருமா.
So now I have almost like
அப்போதான் எங்கேருந்து ஸ்டார்ட் பண்ணணும்னு சொன்னேன் நான். ஹீ இஸ் மை சீனியர்.
Yeah, understood.
திருப்பி வந்து ஹீ
so
ஆஸ்க்ட் தி சேம்
this
கொஸ்டின்.
particular crack was somewhere here. The fish was coming out. Then probably the people will hold on the peritoneum like this. Okay?
Yeah.
And pull it and break this.
ஓகே. நவ
Attachments. They can be done with scissors also.
இங்கே
Also,
புரியுது.
this kind of instrument. So which is not near
இதெல்லாம் வந்து
that.
இம்பார்ட்டன்ட் ஆஸ்பெக்ட்.
And literally also you
இது அவங்க வந்து சப்போஸ் they are following, if they are following, they will easily understand. I don't know. See, this is the pancreatic attachment. Got it now? See, gastropancreatic attachment. I have to release this one completely. See, அப்பதான் fundus. See, you can see a pancreas.
appreciate, sir. There
Yes, yes, sir.
வந்துட்டியா?
if needed, I do
Huh?
1 or 2 millimeter of wood dissection here clearly
ஆமாம், ராஜேஷ் தான் பேசினாரு.
rather than leaving it like this. If it is fine, I can start stitching. And this is the proper placement of the mesh. 15 by 12 mesh. Undivided mesh.
ஒரே நிமிஷம்.
This is Metropolis mesh from AMS. So at our center, later we use 3-point fixation in both procedures, TEP and TMDP. The first is on the corpus ligament, the second is on the medial upper border, which is to the rectus muscle, and the third is going to be on the lateral side. And we use the triangle of pain, where we do not tag procedurally. So there are various methodologies which are available to fix the mesh. There are enough evidence to fix or not to fix. So it is said that non-fixation is equally good enough with the fixation, but we still follow the same traditional rule of fixation, so that we feel comfortable that our mesh will not surely move from there.
Dr. Peish, that was a patient, beautiful dissection, totally bloodless. We enjoyed the dissection. We understood the anatomy very well. Will we continue watching you suturing the mesh? By the time we will go to the other side and come back again.
Thank you, sir.
Thank you so much, Dr. Peish.
எடுத்துடலாம் அங்கே வச்சுக்கோ.
Hello?
Hello.
Sir, we are with you, sir. We saw you
Yes, sir.
short
Yeah.
gastrics. Can you just
Yeah.
explain the important steps in that dissection, sir?
Exactly. I have almost done. I was waiting for you people to join with me because I have almost done. And anyway, I'm waiting for you people to join with me for the dissection of this one. See, phrenological membrane. Okay. So what I have done the retrocardiac window over here, right? Already I have dissected on the left side, and with the right side dissection and close panicko, and I have gone into that retrocardiac window. After that, I have placed one retraction, this umbilical cotton tape, and exactly at the OG junction. So where I can place this one, and I can have this luxury of holding this such a way that I can manipulate this OG junction in this manner. Okay, and one more thing. See, whenever you have started dissecting, go close now. You close panika. See, you have to see, this is the crest, left crest, where you have to leave behind the epimysium or perimysium. Most of the time dissection, what will happen, and see, now we are able to see this one now. See,
Yes,
this
sir.
perimysium, epimysium is most important when you are placing the sutures, which only will hold the knots nicely. So you are completely bared this one only in the muscles. If you are taking the sutures, that can cause ischemia, necrosis, cut through, and the recurrence. So always this perimysium, epimysium is most important. And when you are going up, first I have dissected the peritoneum anteriorly. Once I have come anteriorly, and posteriorly you can see இது பிடிச்சுக்கோமா, இன்னொரு கர்வ்டு ஏதாவது கொடுக்குறீங்களா, உங்களுக்கு காமிச்சிடலாம். கர்வ்டு கொடுங்க, அதை எடுங்க, எடுத்துரு. I'll show you the posterior vagus and the anterior vagus. Dr. Rajiv is also with me. I think you can able to see in the video. So, see, this is the posterior vagus. Can you able to appreciate this one, sir?
Yes, sir.
This is the posterior vagus. It's going inside, right?
Yes, sir.
So you have to leave behind the pad of tissue which is covering the posterior vagus, and going below that one, you can create a nice plane. And same way, kila, ipdi kondu vamo, ipdi, right? Ipdi. Now, after dissecting the peritoneum, right, you can come here. See, this is the anterior vagus,
Yes, sir.
right? And this is the phrenoesophageal membrane, starting from the right side of that crest and encircling that OG junction and the lower part of the esophagus, and it is coming and joining the inferior and posterior aspect over here. See, this is the phrenoesophageal membrane. Can you able to appreciate this one?
Yes, sir.
Right. So we have to divide this phrenoesophageal membrane. Then only you can mobilize the esophagus at least 3 to 5 centimeter. That is mandatory because we have to, the intra-abdominal esophagus must be freely lying, minimum of holding minimum of 3 to 5 centimeter, right?
Okay, sir.
It is the first success step of the fundoplication. Now I am going to divide the phrenoesophageal membrane. You can see here.
Yes, sir.
Once I've divided, I'm able to enter into the mediastinum. Okay, go close little bit. Just gentle dissection like this way. Posteriorly, you will come across that aorta. Camera close up. Go close. Slowly you can extend. See, that is the pleura. Nice avascular plane. Now you can see we have nicely entered. These small attachments, it will free the esophagus, it can come freely inside. Right? Okay. Now on the lateral aspect, see, this is the anterior vagus. See, this is the anterior vagus, right? So I'm coming here. My left hand doing most part of the dissection or giving a traction such a way that all the surgical field comes very closely into the surgical field. So left hand is always equally important like your right hand. So these are the few attachments.
So there is a question from Dr. Rajesh from Koilpudi, leading laparoscopic surgeon, sir. He asked if you can divide the vagus nerve if you want some extra length of the esophagus.
We can, but actually, see, it's a motor function of the stomach. So we can expect some sort of stasis, bloating, this will be there. And most of the time, if you are dissecting nicely into the mediastinum, right, you can easily mobilize the intra-abdominal part of the esophagus than dividing the vagus. Suppose if you are having a short esophagus, sometimes that's also Colles gastroplasty is advocated than the dividing the vagus now.
Okay.
Right? Okay, come. Now the see, this is the final part of the all right. This is the final part of the, see, we have divided right, anterior and left side. Now the posterior part of the phrenoesophageal membrane. So this is the posterior vagus. You can see it's going inside. Now boldly I am going to divide.
Sir, don't mistake me. This looks
Yes.
very simple, but I know it's difficult. But what are the precautions we need to take in this area, sir? Is there any undue bleeding we can have, or whatever? What is that precaution we need to take? Special precaution, yes, sir, or is it routine dissection?
Special precautions in the sense, see, always surgical principles, step-by-step approach, and slowly you have to move forward, and usually no hurry, right? Okay, don't compare with anybody when you are doing the surgery. Always concentrate on this particular surgery. That is why the mantra of doing the successful surgery is that. Now you can see all around it is completely freed, right? Now you can nicely appreciate. So you can see a lower end of the esophagus, and you can see a crest of the diaphragm, right? And a hiatus hernia, and already we have mobilized the fundus adequately to do the wrap, okay? And it started lying down in our vision. It's coming freely, right? And we have to do a shoe maneuver technique to confirm, but it is, see, now we can see it is, now itself it is freely lying down, right?
Okay.
And bleed ஆகுது, right? Okay, இது பிடிச்சுக்கோங்க, right? Suction கொடுத்துடலாம். And before proceeding to the crush suturing, we have to mobilize, see, suction. And this is IVC, right? So we have to be very careful. IVC and aorta is too close, right? So our dissection always to be meticulous. Suction, right? If you want, we can mobilize little bit here also, but it's already freely coming. See, that is the pleura. That is the pleura, right? And if you want, I can dissect little bit further, but doesn't require always. I'll dissect a little bit further. Suppose if you are having a injury to the pleura, no worries. Even if it is a small injury, just give a small gauze over there, right? And you can proceed further. And but you have to inform to the anesthetist that you have injured the pleura and whether hemodynamic instability is there or not. We have to check it with them. And if it is a little bit bigger, then you have to do with suturing with 30 PDS polydioxanone.
Okay.
இங்கம்மா இருக்கு இதானம்மா. And otherwise, if suppose if it is a little bit bigger, 3 centimeter, and there is a pneumothorax, and post-operatively, sometimes you might require placing that post-operatively, perioperatively, we can place a one second. I think we have to release little bit further over here. இங்க கொண்டா. So whether it is adequate or not, let me check with this one.
Sir, good morning, sir.
Yes, sir.
Sir, what is the risk of that paraesophageal hernia after that release, sir?
Which one?
Sir, after doing the procedure, is there any risk for paraesophageal herniation, sir?
See, the thing is, usually any surgery, after the surgery, there will be a fibrosis and this one. And we have closed with the non-absorbable sutures in that crura. Let me see that one. Mostly it won't be, unless if you are injuring that crust too much with the, one second, I'll see what is this one, whether I can, the left here. Right, leave it. One second, I'll come to your question then. One second. Because now I am assessing the one. படிச்சுக்கமா, இதை படிச்சுக்கோங்க. ஓ சாரி, கீழே படிச்சுக்கோங்க. I am assessing the wrap now. Let me see. I think I have mobilized adequately. Just give me a time, 1-2 seconds, right? See, now we can see it's freely coming, right? And either you can do a Nissen's fundoplication or 2-ply fundoplication, and there is an RCT saying that which one is superior? Nothing. Both are giving the same results, but whichever way of procedure you are following, just master on that one, because both the 2-ply 270° or the Nissen's having the same results. Right, okay. Now, what I am going to do, see, now it's freely coming. The most important step is now, right? So I have to close the crura, right? And what articles are saying, the most common cause for dysphagia post fundoplication is not because of the wrap, rather it's because of the crural closure. When you are closing too tightly over here, over the neck, it can cause definitely dysphagia. Why? Because suppose if you are closing this way and there is a post-operative some edema over here and it is not allowing this instrument, then definitely it can cause. Always we have to leave behind at 1.5 to 2 centimeter. This is 2.5. This is 1 centimeter. Till here only you have to make, and by the time relax see, he has to lie down freely. This is the way preventing the post-operative dysphagia. This is most important. Most of the people, because of a wrap only causing the dysphagia, you are thinking no. The article is saying clearly this is because of the crural repair, right? Suction. இது கொடுத்துருக்குங்க எத்திபான் கொடுத்துருங்க suction. That's why I am too slow now today to demonstrate each and every step. We have to understand the surgical principles too. Better.
The transmission is very clear and the demonstration is beautiful, sir. We are understanding the anatomy clearly.
Right. That is because of the 4K. 4K transmission, right? எடுத்துக்கோ. I am taking ethibond. 20 right. Because either you can use the ethylon, this is polyamide, or this ethibond, either one of the non-absorbable, but ethibond only this is the needle is small, that is 31 centimeter, which is 31 or 36 huh? 26 26 centimeter, sorry. But whereas ethylon, one ethylon 41 centimeter. So since you are having a small space over there, and sometimes this small needle will be having a complete advantage, right? That's why I'll prefer to do a ethibond. But there is no hard and fast rules. Anything is fine. Just giving a traction on the left side, go, you have to start from the apex over here, right? So you can see the perimysium is completely intact in both the sides. This is most important when you are doing the dissection. And starting, make sure that, see, always on the back of the mind, you have to think that there is aorta inside, and giving a little traction on the quadrate lobe, right? And the needle angulation is such a way that it shouldn't injure anything. Go close a little bit. Yeah.
Sargama, sir.
Yes, sir.
We just go there, thank Dr. Piyush and come back again. Just 2 minutes.
Sure, sir. Sure, sir. No problem. No problem.
Piyush, sir.
Yes, sir.
So that was a beautiful demonstration. Yeah. Tell us the closing points. Yeah.
So, completed the procedure, just for post-lecture that you have to avoid injury to evidence to again here by closing. As we told while opening up the flap, that is point number 1, and you can keep the pressure transfer surface of the lower flap so that there is no undue tearing of the peritoneal layer, which you can see here. And you should not pull it hard and opposite to the direction. Should be with the flow, and rather than pulling it up, you have to push the peritoneum up. That's how we would be preventing any tearing of the peritoneal flap, and there won't be any balloon holes. And here we have closed the peritoneum, so nowhere the mesh is exposed to the abdominal organs. And we have completed the procedure. We have taken out both the needles out. Thank you so much, sir, for the opportunity.
Yeah.
Thank everyone there.
The one last question, sir. Would you like to deflate and see whether the mesh is getting lifted before you come out? Would you routinely do that?
Usually we don't do that, sir. We don't make a more there to look at it.
Okay.
And if If you want, I can do that from externally. I will try to deflate slowly and look if there is any. Because we have seen inside.
Yeah.
There is a road branch.
Okay.
But exports at least 3 to 4 cent, 3 to 4 mm extra than the needed. So if your dissection was quite okay, bigger dissection, better dissection was good. So I hope that there is no.
Yeah, there are few questions from the postgraduates as well, sir. Before we close, yeah.
Sir, good morning, sir. I'm Mahindan, surgery final year PG, sir.
Good morning.
Sir, I have one question. If we have a patient with irreducible hernia and we are planning for TAP, after we look into the viability of the bowel, there is some part of one circumference of bowel is inflamed, congested. So, and there is a toxic fluid is also there. So, whether we can place a mesh or we have to do something else.
Yes, we have done quite a few cases of similar findings which you are stating now. So, in those cases, you have to reduce it completely, taking down into the abdominal cavity. Then again, the warming time, give some time for the revascularization. If there was any obstructing vessel, which will open up. And if the color changes to, near normal or normal, or if it is changing, then probably that you can go ahead, suck out the fluid, do the dissection and place the mesh and come out. In case if at any point of time you feel that the bowel is not very well vascularized, it is getting towards pre-gangrenous or gangrene, probably if you leave it like that. In that case, at any point of time, please do the resection and anastomosis and keep the placement of the mesh at the second stage, which is not a crime again. We have done few cases exactly which you said, and in almost all those cases that we could, save the bowel, keep the mesh, and complete the procedure in single stage. And then we followed up the patient, and all of those patients did well in the post-op and longer follow-up also.
Okay, sir. Whether we have to keep a drain, sir, in that case?
No, we don't keep a drain because drain will be, where do you keep a drain? Inside the abdominal cavity? Or
Sir, no, sir. Scrotal sac.
Scrotal sac, yes. In case if you find it's a large hernia, in case where there was, incapacitated momentum, where you have to use a hybrid procedure that you divided momentum intra-abdominally and then retrieval of the specimen with a scrotal incision, which is called as a hybrid technique. In these cases that you can always place a small protective drain, or you can even place a rubber drain, closed drain, drain in those cases, so that the fluid collection which happens in post-op will be drained out, and you will not be suffering with the post-op serum as later days.
Okay, sir. Thank you, sir.
Thank you so much.
Good morning, sir. Mohammed Marzouk, sir, surgery PG. Sir, what is the experience with the congenital sac, sir? And if there is a dense adhesion between the sac and the hernia scrotal wall, and if it is not able to reduce it, how can we proceed further, sir?
Are you talking about the congenital hernia in the pediatric age, or if it is in adult,
sir.
You can always give peritoneum to the scrotal wall.
Yes, sir.
You can always suture the different how we keep it here.
Okay, sir. In case of
you need not go so down.
Okay, sir.
Dissect here itself, the indirect sac.
And in case of irreducible hernia, if hernia is not able to reduce, sir, there is due to the dense adhesion between the sac and the scrotal wall, how to proceed further?
Two options. One is, as I said, choose a hybrid procedure. You have a laparoscopic view intact, and then open up externally the scrotum, which is a smaller incision. Divide the additions by open method, and then reduce it, close it inside, and place a mesh laparoscopic, continue with laparoscopy. The second option is, if you are not comfortable, if you find that it is becoming difficult, then probably you can convert the procedure to the open surgery.
Okay. And
it is up to you.
Okay. Thank you, sir. Then
we have done hybrid surgery, where we come in again and place the mesh in pre-peritoneal space. And that's exactly we use in the ventral hernia also. The The larger defects, say for example 5-6 centimeters, where small part is not able to reduce, you find that pulling in from the incisional area at the umbilicus level, you will be injuring the bowel. In those cases, you open up skin over the umbilicus swelling and do the epiphylaxis in open technique, reduce the problem. Close the defect from external itself, it will be more stronger than laparoscopy. And then put a which can be in form of item also and fractures or tampons, whichever area you choose.
Thank you, sir.
Thank you, Dr. Piyush. That was a wonderful demonstration. Very patient, beautiful dissection. We enjoyed, learned the anatomy very well. Thank you so much.
Thank you so much.
Sure.
Sir, Saranakumar, sir.
Yes, sir.
Sir, we are with you, sir.
See, okay, I have done the crural repair now.
Suturing the
And
two
yeah, I have done the suturing repair, 3 stitches, almost 0.5 to 1 centimeter, I can say 1 centimeter, but make sure that 1 to 1.5 centimeter gap between the esophagus and the last suture. This is most important to prevent the dysphagia, right? You can see here, right?
Okay.
And
Okay.
see, it's a freely moving inside, right?
Yeah.
And after that, I'm going to place the. So what do you want, sir? You want to see the toupee or of Nissan, sir?
We saw Nissens in the morning, sir.
Okay,
If
okay,
this is ideal, you can do a toupee.
okay, okay.
Okay.
So actually what you have to do in the toupee, I have to place this right side one first in this one, and see, in the try to place in the midline, automatically it will pull little bit, right? Okay, so
Yes, sir.
not this one as a first, this one as a first, you can make 3 stitches, let it be there, then we can place this one, right?
Okay, sir.
And see, we have see, one marker is already we are placing that this traction just above the OG junction see, this is the OG junction. So, and we are placing from the OG junction to about 2 to 3 centimeter above the esophagus. That's what the wrap concept. And before that, make sure that it should be in the midline. It should be in the midline, and it has to be freely, we can do the suturing. And I am going to take a muscular bite, adequate thickness, here exactly. Sometimes submucosal plexus will be there in the stomach, it can cause shorted bleeding, right? No worries. And because anyway we are going to place a knot over there, even if it is bleeding, just keep on tying that one, give a pressure, automatically it will settle down.
So the stomach suture is a seromuscular suture, or it goes through and through also?
No, seromuscular only, sir, not to the mucosa. And because this is non-absorbable, no. If it is going into the mucosa, it will cause nidus for infection or irritation. So
Okay.
seromuscular. And here also, only muscular, not into the mucosa, esophagus also.
Okay, sir.
And usually we want to keep the Riles tube, and within 4 to 6 hours we'll take out the Riles tube, and we'll once the patient is off from that anesthesia effect or sedation, we can start oral straight away within 6 hours. And first 2 days always clear liquids to liquid diet, and the next 3rd day to 15th day, that is 2 weeks, liquid diet to semi-solid diet to I can say little bit you can go with the soft solid diet. But ask them to chew the diet nicely and ask them avoid coffee or tea or hot drinks or this cool drinks, smoking to be avoided, and make sure that there won't be any vigorous cough or vomiting the first 2 weeks of surgery.
Okay, sir.
And during the extubation also, you have to have a good harmony with the synchronous harmony with the anesthetist. Don't quarrel with them, because if it is a vigorous, like this one, extubation, it can cause sudden disruption of the sutures, right?
Okay, sir.
அந்த sutures இருக்குல்ல உள்ள இதை விட்டுறேன் க்ளீன் பண்ணு. And usually we'll continue the PPI for 2 weeks to 1 month, and after that we can off from that PPI. Come here. Bipolar. Bipolar கொடுங்க. Okay, good. அங்க வா. Come here. படிச்சுக்கோங்க. Right. This is the final sutures. On the right side of the patient. லிவர் பாருமா பாதியோடு நிற்கிற பாரு. ஓகே, அப்படியே வச்சுக்கோங்க. Since it's a non-absorbable nylon, minimum you have to throw 5 to 7 knots. Right. So once being done, இது பிடிச்சுக்குமா? பாரு. பிடிச்சுக்கோ. அனுப்பிட்டேன். Okay. Now this is freely it will come, right? So imagine, see, I have இது பிடிச்சுக்கோ. See, I've made the sutures exactly at the midline, but it started retracting. That's what I told you. So always we have to make sure that close to the midline, finally it will form as a 270 degree, right?
Okay, sir.
Right. Not ஆயிடுச்சா? Right. Yeah. another 2 more bites. And see, in Nissans, we are using only 3 sutures, right? Okay, and 3 knots, I can say. One knot in the esophagus, and so for anchoring. Whereas here, all the 6 sutures on the muscular layer of the esophagus. So, so most of the people are saying that theoretically, but not evidence based. So this will be giving a better this one augmentation than the fun Nissans. But the studies are saying the other way around.
Morning, sir.
Morning.
Sir, Marzuk, sir, PG, sir, finally PG, sir.
Yes, yeah.
Is there any specific pre-operative preparation, sir? Like while operating, we are doing rails tube aspiration, sir. Similar that
Yeah.
the patient need any overnight continuous drainage of the rails tube and like that, sir.
So preoperatively, you see, usually our concept is first in the previous 2 days, that is 48 hours prior to the surgery, we'll ask them to stop this one, so, and hard food, especially semi-solid to soft-solid diet, and 6 hours prior to the surgery, complete only clear liquids only, right? And no other specific this one except for the PPI. If the patient is on PPI, let them continue the PPI. And no other specific this one, because this is a regurgitation this one, no? So we have to make sure that there is no preoperative start scaring or stricture. That has to be dealt first if needed. If it's the stricture associated GRD related complications and the patient is having dysphagia, then we have to do a balloon dilatation, wait for 48 hours and recheck, and if it is okay, do a fundoplication and a periodical follow-up. Not no specific follow-up over here.
Okay, sir. Sir, is there any advantage of that is fundoplication over the magnetic processes, sir?
Yeah, the few of the people start doing that one, right? Okay, because there is a augmented fundoplication, right?
Yes, sir.
One second, right? See, this is the 1 second. This is the wrap to crura stitch, right? So what you have to take, this is the between the last and the other one, and take a posterior aspect, inferior posterior aspect of the serosa. Take a bite. Make sure that you are not going too deep, because deep inside is the aorta. That's why this needle always preferable than the ethylon. This one is a very important step to prevent the wrap migration. What they are saying, this suture is most important. coming to the magnetic augmentation of fundoplication, and even though there are few papers, they are not having any added advantage than this Nissan's or two-pay fundoplication. I think we have done with this one, right? You can see, Puduma, your bowl holding. So I told you, no, even though we are starting from the center point, it will start to see. I've taken as if I'm taken the close bite. It will start stretching, right?
Yes.
Okay, and see, you are leaving being. This is 2 centimeter. So 2 centimeter anteriorly it's free, and posteriorly completely covered, and this is called two-pay fundoplication, right? And make sure that there is no bleeding. Suction.
Sir, no, sir, as you are closing,
Yes.
I'll just go to the other side and come back, sir. 5
Yes,
minutes
sir.
and go
Yes,
and
sir.
come back. Yes, sir.
Yeah.
Thank you, sir. Hello, Sandil, sir. Sir, morning, sir. We are with you, sir. Parastomol. Okay, sir. Okay, sir.
This patient has got a plaque extending from the disease sternum to symphysis pubis, and this patient has got a paraform hernia at the site of the cardiac, and patient has got a difficulty in emptying the urine due to some hypercoagulation or some mechanical issues. So this patient was supposed to be done at the hospital today. So we actually asked Dr. Ganesh Kawal, he said, okay, we can do it at live surgery, so we should be thankful to him. And we have posted the case for this repair.
Thank you, sir. Sir, with so much of surgeries and so much of additions, how did you make a port entry, sir? Yeah, that's what.
So what we have done is we have done entry at the front area. This was the first floor. These are the first floor.
Yes, sir.
This is telescope and the telescope we have dissected then what we in the 10 dissection we dissected completely because everything was done to the angular norm.
Yeah, as we could see. Yes, sir.
So we using a telescopic dissection we created a space for the tendon of protar which is camera both which is the second protar. So first protar is then subtracted that there is a normal position like that.
Okay.
With the telescopic dissection, we created a plate for is here, the second port, and then we further dissected down and we have created another port for the left hand working. But after we are trying to use the force by port for addition because the system was not reaching. So we have created a more additional port here so that the system can reach the operating area comfortably.
Okay, sir.
So this is the port placement.
Okay, sir.
So here every account has totally glass tiles. So luckily these are all hospitalizations and easily separable medicine. So that's why we are able to release it by using telescopic dissection itself initially. Then now we are doing a soft dissection. So when we are doing adhesive lysis, the counter traction is very important. So you should use your left hand and right hand equally, and they are just as identified the traction for the blade to open up. So this is the attachment so that it will come down. It's a very large hernia, I can appreciate with the external camera. Very large hernia. Are you able to see the hernia? Of external view now? So you can appreciate very large hernia.
Yes, sir.
Very large tract outside. And the stoma is here, that is the real conduit stoma. And huge defect, so you have to be very careful. You have to go very slowly and carefully.
Sir, for 5 minutes, we'll go to the other side and come back for the closing remarks, sir. Saranakumar sir is completing a fundo, sir. 5 minutes, sir. Thank you, sir. Saranakumar sir,
Yes, sir. We have
with you,
removed,
sir.
yeah, we have removed that
Yeah.
two sutures and the gauze pieces. Everything we have removed,
Yes, sir.
and including the one fat. One more fat is there or not? Irma. 1 second. Yeah. Right. Yeah. Right. Yeah. I'll going to give a wash and come back. Right. Okay.
Yes, sir. So there's we also have a hybrid thing going on, sir. We're
Yes,
streaming
sir.
on YouTube, and there's a question on the YouTube asking that are there any other methods of retracting the liver apart from this? There's a question
Yes,
on the
sir.
YouTube channel. Then, so
Yes,
he's
actually,
asking for some
actually,
retraction methods or some
கொஞ்சம் head down பண்ணு. Either, sir, either we can use this type of retractor or Nathan's retractor, or we can use a sling technique where we can take a bite from here. That Freno is head down மட்டும் பண்ணுமா. Freno is take a bite from here and we can retract from here, go above, and anterior-abdominal we can place that one, or sling technique. Sling technique also, you can take a rice tube, right, and place it in that non-absorbable maybe ethylon, and throw anterior abdominal through pierce to that liver to the anterior abdominal wall, not to the diaphragm, here anterior abdominal wall, pierce here and place a rice tube over here, and that suspension, this is called suspension technique.
Oh, okay, sir. But this seems to be the simplest technique of all, sir. Very simple.
Yes, sir.
Visualization also good.
That's exposure is very nice over here, and
Yes.
in such a way that we have to place the retractor trocar. That's it.
Okay.
And we need one person. That's all. But it will be nicely. We can do a retraction. This always do a irrigation and suck that area, and otherwise sometimes patient have some sort of pain, shoulder pain, and this will give post-operative less pain comparatively. That's why we are always using the after இது பாருங்க சக் பண்ணிக்கோ ரைட் சக் பண்ணிக்கோ சரி சக் பண்ணு போர்ட்டில் இருக்கு ரைட் போதுமா ரைட் சக் சக்ஷன் கொடுங்க தட்ஸ் ஆல் சார் ஓவர் எனி கொஸ்டின் சார் சக்.
So that was a beautiful demonstration. So we have seen 2 fundos from since morning, and I think my professors and assistants will start doing the initial workup for a fundo. Thank you so much, sir. That was a wonderful demonstration. Any questions from the audience? Surgeons? Yeah, ask.
Sir, good morning, sir. I'm again surgery PT. Fine with you. Sir, have you ever tried combining selective vagotomy with fundoplication, sir, in post-operative benefits?
Selective vagotomy in fundo.
Yes, sir.
Why specifically? Because vagotomy usually will prefer for gastric outlet obstruction with severe ulcer is there, we have to do that one. But in fundoplication, I don't know. Is there any entity called vagotomy with fundoplication? I don't know. Have you come across any articles?
Yes, sir. I saw an article, sir, combined procedure of a truncal or selective vagotomy with fundoplication. So that's
Is there what is the advantage over there?
esophagitis and all would be useful like that. It is mentioned, sir. That's why I'm asking.
No, the thing is selective. See, if you are doing that selective vagotomy, sometimes you can have a see. If of course there is a pyloric spasm can cause some sort of a bloating, stasis will be there. Even after fundoplication also, because of we have manipulated the fundus in such a way that there is a edema for 2 or 3 weeks, it can have some sort of a bloating early satiety. In that, if you have added this one for selective vagotomy, it can augment the effect of bloating and the early satiety. I don't know. Anyway, let me go through the articles and let us have a discussion then.
Okay, sir. Thank you, sir.
Right. Yeah.
Marsuk, you have a question?
Yes.
Yeah.
Sir, how to follow up the patient and when we have to call it as a recurrence? How to diagnose the recurrence?
Yeah.
After this.
See, actually, recurrence, no. There is one article saying that it's a confirmed, it's a meta-analysis saying that almost 30% of the fundoplication, either it is a toupee or Nissan's fundoplication or mesplasty, radiologically at least 30 to 32% of the patients having recurrence. That's what that article is quoting, that one. And this is after 5 years study of that fundoplication. So in that, what they are advising, see, suppose it been what do you call, suppose if you are seeing the endoscopy or CT scan, you can see a small 2 centimeter of the that RAP migration. It can be called as a recurrence, but that is a radiological recurrence. But to say that, you have to assess the patient clinically. Suppose if the patient doesn't have any sort of clinical evidence of esophagitis, including the endoscopy, except radiological evidence of RAP migration, those patients need not to advise for the redo fundoplication. And the chances of redo fundoplication in those 32% of that one, only less than 2 to 3%. That's what that article is saying. Is it clear?
Yes,
Okay,
sir.
sir. Thank you, sir.
Yeah.
Any other questions from the audience? Thank you very much, Sanakumar sir. That was a wonderful
Yes, sir.
demonstration.
Thank you, sir. Thank you so much. Thank you so much.
Come back again. Thank you, sir.
Right. Thank you, sir. Thank you. Right. Yeah.
Sendil sir? Yeah, we are with you, sir. So what are you planning for this patient, sir? Sugar waker or what, sir?
Actually, I'm planning for sugar backer only.
Yes, sir.
What I see the design, normally sometimes even in the one case because muscle everything was very weak, and so most of our experience are with only.
Yes, sir.
But recently we have done few cases of sugar bracket technique, where the breast will be lying over the defect, so that the recurrence will be reduced. Sugar bracket, legal technique is also good. You have to close the defect very nicely and raise the breast with the keyhole just to accommodate the bone to come out.
Yes, sir.
So here what is required is patience, and because of the sac which is protruding outside, you have to push from outside so that it will come into view. So sister is pushing from outside, and brother is pushing from outside, and we are trying to visualize the fundus, or this is the fundus of the hernial sac, which is a very large sac. So the dissection will be done under vision. So always manipulate from outside and try to visualize the adhesion which is there at the fundus. Because otherwise you can see only the exit point, but you cannot see the site of attachment. So you can see a lot of convolutions are coming, until now it's only one. So beyond that, we can simply say that these are all convolutions going inside. So I'm trying to release all these momentum fast, then I will go for the anatomy area where all is exiting. So combination of blunt and sharp dissection always try to go and visit the adjacent at the site. Sometimes if you cut it here, the remaining water will be revascularized and it can cause necrosis in the post-operative period. So always go and elevate the adjacent at the level of at the interface between the canal wall and the actual adjacent. So main thing is we have to clear the mechanical obstruction which is causing trouble also. So we have to completely mobilize we have to see the entire anatomy before actually going for the repair of the hernia. Because otherwise the hernia will be repaired and facing a persisting problem. So we should try to identify what exactly is the cause for obstruction. Using the 90-degree scope. This is a wall. This is so we'll release the bowel completely, reassess the anatomy, then we'll go for a direct therapy. So if you are having any doubt, say this looks like one change and see the opposite side, then you will come to know that it's only adjacent. Otherwise, fibrosis will look like a ball. So this is the loop, and here there are some adjacent so much of which is remaining. I have tried to remove this. Rest everything is normal only. So this portion I have taken out. Push is given out from outside, and the tool is given from inside. We have changed the scissor to cover the sector so that we can get better traction. Try to go as high as possible. And I know that there is no power.
waiting ரெடியா இருக்கான்.
Sir, as we are watching, we will move on to the other side and come back to you, sir. Thank you, sir.
Hello.
Morning, sir. We are with you.
Good morning. I'm Dr. Harish. Can you hear now?
Yes, sir.
Yeah. I'll be showing a case of anterior section. It's a minimally edited video of anterior section. What I've done here is I'm going to show you a case of robotic anterior section. Basically, the procedure, the way it is done, everything is identical to laparoscopic anterior section. So let's start first with the port positions. The first port position, what I've shown here, is the port position for laparoscopic anterior section. So based on the level of the umbilicus and how depth you are going to dissect in the pelvis, whether it's an AR or ultra low AR, based on that you place the camera position. The camera is about a centimeter and above the umbilicus to the right or at the level of the umbilicus, depending on how deep you want it. So if you are going to dissect it deep into the pelvis, then what will happen? The camera will require a little more reach. So about a centimeter and a half at the level of umbilicus will suffice. And then we place under vision the left and the right working port, which will be the main working port for us, main working port. And the suprapubic port, initially the case starts with a 10 mm port, where it is used for stapling of the vessel. At the last part of the surgery, the same port is converted into 13 mm, where a stapler is used. And at the end of the same port is used the meningeal incision. And there are two traction ports given. The first traction port near the left hypochondrium is optional. If there is a fatty patient, there is not a retractor hole, we can use that one. But the second traction port at the left lumbar region is then compulsory for retracting the IMA pedicle and the sigmoids. So these are the main port position for laparoscopic. When we are doing robotic, it's almost the same except that the two working ports and the camera port come into a single line, almost a single line. See, because we have to reach much more tangentially in robotic, so we put the port slightly below towards the hypochondrium and then two ports triangulate towards the point of dissection. So first what we are going to do is with the second traction port, we are going to lift the sigmoid and the IMA pedicle and give traction and tenting to the mesentery. Like I told in the previous case, there is a Toll's fascia extending from cecum up till the rectum. In the rectum, the same is called as the TME plane of dissection. So what we are going to do, we are going to stick to that plane now by first incising the peritoneum at the level of the promontory and then extending the incision towards the DJ flexure. Inferior mesenteric artery comes out just little distal to the DJ flexure. So we need to put our incision towards that one. As soon as you give adequate tenting, the gas itself partially dissects and you can see the TME plane is already opened up. So incision continues superiorly. You can see the pulsation adjacent to the incision, that is the pulsation of inferior mesenteric artery, and here you have the aorta, then aorta goes down and bifurcates into iliacs. Now once we put the incision, then we have to look for the pulsation and then clear all the mesentery and the fat tissue away from the vessels. This is the TME plane which we are working. Slowly we are coming superiorly. We can see the lymph node near where I am dissecting right now. At this plane, if we go deep to this fat which you can see below, you will go almost near the psoas muscle and you will end up injuring the ureter. So you need to maintain this fascia right in the right plane so that we don't injure the ureter at the beginning itself. Now we can see lymph node and the pulsation of the superior mesenteric vessel. Now I am going to trace the superior mesenteric vessel proximally to its origin of the aorta. Here what we do, we stick very close to the vessel. You can see one small nerve running there. We have the plexus of nerves, aortic plexus is present over there. So we have to be very careful. It is running right below the peritoneum. So you have to give adequate tenting to the peritoneum and then slowly cut the facial fibers and then push the nerves away, like you slowly push the nerves away towards the posteriorly, so that most of the nerves are preserved. That gives a better outcome for the patient at the end in long term. The left side, the nerves are slightly closer compared to the right side. So you have to be also careful when dissecting the nerves. Now you can see lot of nerves running around here. There's a vessel and there's a lymph node there where I am cutting right now. So I am going to go below the lymph node and try to separate and take away the lymph node towards the specimen. The pulsation above is the inferior mesenteric artery pulsation, what you are seeing, and all the along with the nerve fibers you can see all the facial fibers. I am going to show the nerve fibers now. This is all the fatty tissue. I am just small cautery or with a harmonic you can cut and then push away the tissue so that the nerves goes posteriorly. You can see the other nerves on the left side, and here all the nerves we can see here. These are the aortic plexus of nerves here. From the pre-aortic plexus, hypogastric plexus of sympathetic nerves come down. The initial phase very important to preserve the nerves.
Because we have a good range of motion in robotic, doing the surgery is much more easier, and the vision is very nice. We can go very close to the tissues and you can control the camera, so the results are much better. Now you can see the IMA very nicely. You can see the pulsations there. You can see up to the origin of the aorta. Again on the left side I am dissecting and pushing the nerves away. See, there is a nice thick pedicle of nerves coming down. I need to slowly go, separate it from the vessel and then push it downward. These nerves, the plexus are there on the vessel also, and the same plexus goes laterally towards the gyrotous fascia also. So even when we are doing the surgery and when we are separating the gyrotous fascia, we have to be very careful as to not to breach too much of the fascia, because the nerves will get damaged. The patient is head down position in a semi-lithotomy position, so most of the bowel is fallen behind. In fatty patient, what will happen, the bowel keeps coming into this field, so that's when the traction port in the left hypochondrium is placed and bowel is pushed away with a fan blade retractor. See, now you can see the markings which I have shown. These are the nerves and the gyrotous fascia on the other side. Slowly, little by little, I cut the nerve, the fascia and push the nerves away. Here 1 or 2 nerves will get sacrificed. It's not possible to save all the nerves, but to the major extent try to save and push the nerves away instead of sharply cutting everywhere. The procedure is identical to what we do in laparoscopy. Here in laparoscopy we will be using a harmonic, or you will be using a scissors or a hook to do this. Preferably a scissors or a Maryland or harmonic, you can use any of the instruments you are comfortable with. These fine dissection, generally harmonic gives a very good result. So once we have come there, now you can see the DJ flexure where my bipolar is there. Just below that is a DJ flexure, that is just below that is the IMA origin. So from that DJ flexure I am just going superiorly following the flexure. Now I will reach the inferior mesenteric vein, IMV is there. So next part is clipping of the IMA. So I am going to make a circumferential dissection all around and clip very close to the origin, so that all the fibrofatty tissue comes off along with that one. You can give a better clearance then. You can either use a metal clip or a hemolock. Here we have used a hemolock. 2 clips on the proximal side and 1 on the distal side. Making some space now for the distal clip. I am showing this part video. This was a part of a robotic TPC which we had done. So the now IMA is cut and you can see the nice pulsations. Once that is done, you stick to the gyrotous fascias and dissect superiorly. So the suprapubic port, what we had poured, our assistant surgeon will hold the mesentery and he will tent it so that it will be easy and the traction will be better. The tissues will slowly start opening upon its own. Most of this as a avascular plane, like this is the Tolles fascia which I am dissecting. So as I go superiorly, now next step for me is to check and identify the IMV and then clip. IMV is ideally clipped close to the pancreatic border. From underneath that it goes under the pancreatic border. At that point we have to go and clip that one. Sometimes because you can see the bowel is falling down, it is difficult to trace until the pancreatic border in the initial step itself. So for completing the surgery, what we do, we just clip as high as possible, and when we do the splenic flexure mobilization, if pending pedicle is there, then we clip it there. But ideally it's best clipped at the near the pancreatic border. skeletonizing the vessel so that the clip will sit nicely. So you use both the hands, one hand helps the other to do the dissection. Now nicely skeletonize the inferior mesenteric vein. Now I am going to clip it. This dissection, superiorly you have to go until the inferior border of the pancreas, that is the extent of dissection. So most of the time when we follow the Gerota's fascia superiorly, there we are going to encounter the inferior border of the pancreas. And when giving traction, try and avoid holding the pedicles because that can cause lot of bleeding. The clip can get slipped off from there. So IMV is now being cut. See again, once that is done, again we are giving the traction and then slowly we are dissecting. Now identify the Gerotas. You can see the ureter will start coming at around 6 o'clock position below slowly. Now I am pushing the Gerotas away from the mesentery. You can see the gonadals over there. So I am pushing it slowly away. Adjacent to the vessel, you can see one thin white color structure, that is the Gerotas fascia. That fascia needs to be pushed downwards, that is towards posterior. Small electrocautery, release the fibers and then push it down. You can see the ureter now below the gonadals, nicely ureter movements are there. Nice peristalsis we can see. Again, our assistant from the suprapubic port, he is giving the traction for my procedure. See, now like I told you that time, thin built patient, the Toll's fascia is very sparse. So separating and identifying from the mesocolon is slightly difficult. So you need to have adequate tenting. In a fatty patient's BMI around 30 or 35, this fascia is very nicely seen and easy to separate. We generally under the impression that the thin patient we can give its surgery is going to be easy. Of course, most of it is going to be easy, except this part it's going to be little difficult. See that fascia is so thin, just above the fat you can see the fascia. Now we have come to the inferior border of the pancreas and you can see kidney below. There is a very thin Gerotas fascia and a Gerotas pad of fat, and through that we can see the renals, left renals. You can now see the ureter, gonadals going. So I am holding a thin Gerotas pad of fat and then giving a traction and separating the mesentery away from that. Again, when doing laparoscopy, ideal instrument would be a harmonic for this, or if you have a scissors, you can use a scissors, or whichever instrument you are comfortable, you can use. There is no hard and fast rule which instrument has to be used for this. Which is comfortable for you, you can use that. The traction has to keep shifting. So each location where you are going to dissect, the traction has to be maximum at that point. Only then the tissues will nicely separate from each other. You can see the kidneys are very well seen now. See, when we are doing robotic, even though the procedure is identical to what in laparoscopy, the way it is done is slightly different. Laparoscopy, you give more traction, you push the tissues a bit more away, but robotic is a machine of for precise dissection. So little by little, layer by layer, fiber by fiber, you go on dissecting. So you will get very good results through with that one. But the plane of surgery, everything is identical. Even laparoscopy, we do the same procedure. So slowly I am going laterally towards the Tolles line. Now that's the colon, lateral to that is the Tolles line. So until then we do the dissection and separate all the fascia away. Gerotas is separated here. You can see through the tissue, you can see the opposite lateral wall there. So we have come to the almost well laterally we have gone. Now we open the Tolles line at the lateral border of the descending colon. Toll fascia goes laterally and there slightly condenses. Of course, it's a slight, always a doubt whether how it is formed at the lateral border, but most accepted it forms a condensation there and forms the Tolles line. As we go superiorly, we encounter the spleen. Now we are at the upper part of the descending colon. Now this is the left iliac fossa. The sigmoid is separated, being separated from the lateral borders. See, the gas goes inside and automatically dissects. So this is a classical medial to lateral dissection where the pedicles have been taken into task at the beginning itself, and then we do the lateral dissection. Now at this point we have to be careful. Once the inferiorly, posteriorly we did the dissection, and when we are doing here, if you lose the plane, if you go little more deeper here, we will end up injuring the ureter. So stick close to the vessel, give a good traction, separate the tissues, and then once you do the dissection, only then start cutting the tissue under vision. These are the appendages which are stuck. Slowly, little by little, I have to separate that. Scissors is a very good instrument. You can cut at the same time coagulate. See, little by little I have to give traction and separate it from there. If I go deep there, I will end up injuring the ureter. So what you can do is when you are doing the posterior dissection, you can leave a gauze at this point. So when you come from this lateral dissection here, you identify the gauze and you know exactly where you are dissecting that time. See, now given the traction, now I can see the gonadal vessels going there, so I can separate the tissues away from that. So again I come to the medial side and releasing little more tissue because it was not adequate from the other side. This is the gonadal and the ureter. You have to separate the ureter from that. This is the location where gauze is placed ideally before starting the lateral dissection, so that when you come from the opposite side, you come to the gauze exactly and you won't miss the plane. You can see the ureter to my left side, it is gone behind this tissue. You can see it now, and the gonadals. See, this vision is wonderful in robotic, you can go close, identify all the fibers, layers, and exactly dissect the point where you want to dissect. So most of the gerotas have been separated and taken down. This particular side of the dissection was a part of TPC we had done. Now we can identify the entire mesocolon and the colon is lifted up. That's a white line of tall there. So I'm separating and the entire colon is being separated now. Only the lateral attachment is to be released. Now you see it's so much better once we do the dissection. The last final few attachments from the descending colon, the sigmoid laterally is being released now. Left hand instrument bottom is a curved grasper, also a bipolar. In the meantime, colon can here we can give a medial traction to the descending colon from a traction ports. We have two traction ports, no, left lumbar and left hypochondrium. The assistant surgeon can give a nice traction here. So as we go superiorly, we are coming to the splenic flexure now. The spleen is visible up there. The splenocholic ligaments, as we go higher, we need to be released. So what extent you can do from one position, you complete the dissection. After that, we can shift to the next side. So in the same port position, now I am starting the mesorectal excision, TME. Now giving traction is very important and sticking to this plane is very, very important, because our endopelvic fascia has visceral and parietal layer. All these nerves, now see there is a nerve right under my instrument there. That nerve, it is under this fascia. So you need to go above that and slightly separate and then push it posteriorly. This is one of the locations of nerve injury. It is about 2 centimeters medial to the location of the ureter near the promontory level. So you have to be very careful. Here a very good traction, giving traction anteriorly from a suprapubic port and the left traction port and with your left hand instrument. All three instruments will come into play while giving the traction here. So stick to the plane, slowly release the fibers and go inferiorly along the mesorectal plane. The first dissection is the posterior dissection. First posteriorly we need to go as inferiorly as possible and then do the anterior dissection. Only then we come to the releasing the lateral pedicles. As the hypogastric plexus comes down, it carries the sympathetic nerves, and at the level of S2, 3, 4, nervi erigentins, that is the parasympathetic branches, they come out and then they at the Y shape they come and fuse with the sympathetic branch, and from below there onwards it's mixed branches, sympathetic and parasympathetic. So see, you can see on the left side the nerves are coming out. As we come down here, we encounter the Valdeir's fascia a little more inferiorly. It will be thick fascia in the midline, so we need to cut that. Only then we can enter into the complete pelvis, into the lower part of the rectum. This is partly I am doing the lateral dissection. That is the TME plane. Now you can see it has got a bit thick here in the midline. See, laterally it is nice, open. When you come to the midline, it's slightly thickened. Now we need to break this fascia, and only then we will be able to enter into the lower rectum. To do this, we have to give, see our suprapubic port, they are giving traction. They have held the rectum, we pull the colon out and then anteriorly. So it will nicely tent at the level of promontory, and then with your left hand you can push the rectum up and you will get a nice traction. Again, see this is the fascia swelling in the midline. It's slightly condensed and thicker. So we need to break this fascia nicely. Be careful when we are dissecting here. The posterior, what you are seeing in the presacral fascia, that has to be left intact. If you go deep to this presacral fascia, there are veins which will get damaged, and it is very difficult to control the vein. So make sure that this fascia is left intact. If you breach the fascia, you are going to injure the nerves, you are going to injure the veins, and that's going to cause lot of torrential bleeding, and it's very difficult to control that one. Difficult to bipolar, difficult to take a suture. You have to use a gauze and then very tightly pack it and keep, and then use a bipolar for that one. So you need a lot of patience, and slowly you need to develop the plane in the mesorectal plane. And of course, there's always a controversy regarding the lateral ligaments. There are 50% of the surgeons say there is a lateral ligament, they swear by it. Another 50% they say it is not there, it is a false ligament created due to the dissection. It looks like a ligament. So either way, when you come to the lateral side, you go little carefully, because middle rectal vessels can be there. That is the location of the middle rectal vessels. From the lateral ligament it comes. See, now again I am right now in the midline trying to open the, see that fascia has now slowly opened up. Well, as soon as I open this, you will see nicely the plane opens up now. See, the plane has opened up. I need to break this fascia slowly. See, now I broke the fascia. You can see again the plane started opening up nicely. Stick close to the rectum. Don't go far away. This is the place you will injure the ureter if you go very far. Very close to the rectum, you have to stay here. And if you go far, what will happen as you go? What I'm palpating here, there is the lower part of the sacrum. If you go very laterally, you will injure the nerves, pelvic nerves also. After nervae urgentis comes out in the S2, 3, 4, below that pelvic plexus forms. So when we are going, if you go very laterally, you can see at, if you see at 9 o'clock position, you will see a thick pad of fat above where I have cauterized. If you go around that one, you will injure everything. So you have to stick close to the vessel, stick close to the rectum. That's the location I was telling you. You need to stick where I am dissecting right now, not lateral to that one. From there onwards, below pelvic plexus will be there. These pelvic plexus nerves, no, they go anteriorly, anterolateral to the prostate. So if you are going down, anterolateral to the prostate is where it will be resting. So when you are doing the dissection, if you go deep in that prostate area, again you are going to damage the nerves. Now posteriorly I have completed. Anterior and lateral is pending. To the extent that is required for me to dissect, I will mobilize the lateral part, but the next part of the dissection logically will be the anterior part. Again, see, when we give traction here, the denonvillous fascia nicely it opens up, and you need to go just posterior to that one. Keep close to the rectum. See the traction I am giving. The colon is nicely pulled out, and then from above the bladder is pulled up. Now the prostate is come into the picture. Don't go deep here. Nicely the fascia goes away to the other side. You can see in the exactly in the midline where I have dissected, I have gone above the fascia. You need to stay slightly one layer below that one. See, what I am dissecting right now is a right plane. If you come to the midline, you can see one small breach in fascia is there. I need to open this, go underneath one. See, this is, you should not go in that plane. See the triangular piece you are seeing in the midline white color, that should be onto the prostate side. Again, traction, shift the traction to medial lateral and then slowly dissect. Same surgery will be done with a harmonic or a hook in a laparoscopy. Same ports, same procedure, same identical techniques. Just the instruments are different here. Slowly the levator ani muscle is coming into the picture now. Anteriorly what we are having is the prostate, and as we go below, next is the seminal vesicles will come. So just stick to the plane close to the rectum, push the fascia away and you are safe. So this is what I have done here in ultra low anterior resection. So if it's an anterior resection, a low anterior resection, whichever level you are doing, you need to transact the mesorectum at that point. See, these are the pelvic plexus. You can see the nerves at 9 o'clock, 10 o'clock, 11 o'clock position, the nerves coming inside there. So if I go lateral, it will get divided. So I am sticking very close to the rectum now. So I am working at the seminal vesicle level now, almost coming to the levator ani. So when we are preparing the rectum for transaction, you have to completely cut the mesorectum posteriorly and laterally. So you can use a harmonic or a ligosure, but when you come to the posterior part of the rectum, that is around 6 o'clock position, when you come posteriorly, superior rectal, the inferior mesenteric artery continues as superior rectal. So that artery will be there. Sometimes you may have to clip and cut it, not directly go through with a scissors or a hook. Even with the harmonic, sometimes you may have to clip it. Harmonic or a ligosure, most of the time it's a good instrument. It can cut without any problem, you may not require. Occasionally it may bleed, you just have to apply a clip in the posterior part that time. Again, when you are preparing the rectum, you are going to staple very close to the transected part of the mesorectum distally. So don't leave a bare area of rectum and then apply the stapler. That is going to cause definite anastomotic leak. You have come to the levator level. The rectum has been nicely pulled up. That is why it is looking above. Once you see, notice once I leave the traction, it will dip into the levator. Here the assistant surgeon is very important because only by their traction I will be able to do a good surgery. You have to take your time, don't be in urgent here. Slowly, little by little tissues, tease it out, separate the rectum. This working the pelvis is one thing I found extremely useful when using when doing with the robotic. This vision, getting assistant camera inside, he holding it stable, it's going to be difficult. With this ports into the pelvis, it's really wonderful to do surgery with robotic. So when you are doing this ultra low and all, sometimes you need to have, ideally if you have sigmoidoscopy it is better, because post radiotherapy we would be doing a lot of cases. So sometimes the tumor will be very small, you may have to re-identify the tumor, then decide on the level of transaction. You can use a PR if it's palpable, or alternatively sigmoidoscopy during this time and identify the level of transaction for me. See, that is a level, that is a levator level.
If you go straight in between that levator and the rectum, that will be the intersphincteric space. I don't need to do intersphincteric dissection now. If you go in that level deeper, continue the dissection in that level, that will go to the intersphincteric plane. In post radiotherapy patient, there will be lot of edema fluid and tissues will be little more edematous. So sometimes getting the plane may be slightly difficult. So once that is done, now shifted the camera superiorly. Now doing the splenic flexure mobilization. Now between the omentum, between the transverse colon and the stomach, I am opening the omentum here, and I continue this up to the spleen. Single procedure up to the first layer to be removed is the omentum. Continue up to the splenic flexure. Here again the traction is required on the stomach side. Once it is lifted, and the traction on the colon, both of them, if you give good traction, it will nicely tent up and go in between these two instruments. So now I am coming the first layer, that is the omentum. I come up to the spleen now. Once it is done, next is identifying the lower border of the pancreas. Most of the time it will be seen, well seen through the mesentery peritoneum itself. Now because we have already come from below in the our Tolles fascia from mesentery, we have come below until the lower border of the pancreas. Now it will be very easy for us to identify and open the peritoneum and go into the posterior part. This is a pancreas. So you can see some small openings below where we have already dissected on the posterior aspect, just below the vessels. I am clearing the last bit of omentum that is attached to that. You can see that transparent area. I need to open one of those areas, get to the posterior part. Most of the time here near the ligament we will get one vessel. If you have a good bipolar, you can use that, or you have to clip sometimes, like I will show you now. Now see, this is already the dissected area below. Until there I have already dissected. Now all I have to do is connect this dissected area, that is the inferior border of the pancreas, along the border of the pancreas. I need to go laterally and completely mobilize the splenic flexure. I told you that time superior mesenteric vein from the lower border of the pancreas, because of the bowel was coming into the operating field. So I don't need to struggle and go and clip the pancreas inferior mesenteric vein in the immediate itself. Once this procedure is done, the vein is seen directly here. At that time I will go and complete the dissection, just put a clip at the lower border and separate it off. Here we have few lymph nodes and we have two vessels, veins coming here. So I need to identify the veins and then clip them individually. These are pretty big veins, so you have to be very careful. These veins are not at the level of omentum. This is at the level of once you open the peritoneum, and below that it will be there. So at the lateral border of the pancreas, when you are dissecting, you please be careful at this point. These two veins have to be clipped and cut. Even if you have a ligature, it is better to clip these veins. Generally, what we have seen is they tend to be slightly in larger caliber. Again, here assistant will make a lot of difference in giving a good traction. Now once this is cut, then the last part is separating it from the splenic flexure. So what we saw was one layer of omentum, and then we saw the layer of peritoneum above on the anterior of the pancreas, and then posteriorly we had a layer from where we had dissected from the mesocolon. So all this layer need to be taken away, and a complete splenic flexure mobilization.
is done. So this is a complete splenic flexure mobilization is done, and this is a separation of inferior mesenteric vein. So that is clipped, and mobilization is done medially till the middle colic, because if you are going to do ultra low anterior section, then you need to have a complete free colon. We don't want traction at the anastomotic site, because that is the one stress at anastomotic site will give chance to leakage. So once I have cleaned the entire thing, and then I am going to apply a stapler. This is a completed dissection. This is a second stapler being applied. In females, you have to be careful of the vagina above. So point your staplers away from the vagina. Make sure the vagina is separated from the rectum before applying the staplers. So specimen is brought out through the phalansteal incision, and this is the IMA pedicle. From there, we are giving adequate margin and cutting the specimen. And then an anvil is, this is the cut end of the stump which we are closing with a suture. The anvil is placed, and we take a purse string suture around it to hold it in place. Once it is done, we push it back into the abdomen. A stapler is from the assistant surgeon, he passes a stapler from below. So an orange mark is there in the anvil, so that has to be well seen. When before placing the fixing it to the anvil, make sure that the mesentery is medial and there is no twisting of the mesentery, and pull out all the bowel and the fatty appendages away from the anastomotic site. Make sure that it just bowel to bowel anastomotic, no other structure is below. Each stapler, they have their own way of applying. It's slightly different. Once it is done, these are the donuts you have to see, 360 degrees. Finally, a leak test. Air is blown. You saw the air coming inside. There is no leak. After that, we put a drain and close the abdomen. Yes, thank you.
Thank you, Dr. Harish. That was a wonderful demonstration.
Thank you, sir.
We were able to visualize all the anatomy. Thank you very much. Thank you.
Thank you, sir.
Thank you. Hello, Sandil sir. Yeah, we are seeing your patient adhesive lysis, sir. A tremendous job you have done. Yes, sir.
This is when angle view, then you can go to the other side. What you can create almost the just completely from there, has come out. So sometimes if you are not editing anything in this angle, so then you can put almost in the right performance area, then you can see the difference in the different angle. Most of the time you'll be able to like the distance. Because here this power is hiding, this mesentery is hiding, So once you place another foot, this then you can see the difference in the different diameters. Only one more is everything is done. Sand. What is the location? I am asking. So this minimum I am changing it to 10 mm. I try to see from above whether the addition context will give some opinion. So the camera they came with actually this is a very autoclave class and they autoclave the saline also and they feed it. So that itself looks healthy. One lab give me a second. So if there's some additional information.
Yes, sir.
This way. And the side it was looking whether they're seeing a muscle or bone, there was a confusion. Suction. cutting the sac. So this is going above layer, cutting the sac and trying to avoid injury to the small bowel. three, sir. So this is a chronic illness. So once this is actually this obstruction is having some trouble for me. It's got difficulty in voiding urine to swallow into this obstruction.
Obstructive uropathy.
We can completely clear all this thing before actually doing this swallow repair.
Okay.
Spinal repair.
Yes, sir, I can see.
So I try to introduce a catheter inside.
Catheter and there is a
Senthil sir, you are planning to close this huge defect from inside, sir?
We're trying to close huge defect by using wax sensor and
Okay.
then place this on. So you can appreciate the containers coming here. Are you able to see the
Yes, sir. Yes, sir. Yes, sir. Very well.
So that is the bowel which is the conduit. And
Senthil sir, as we keep watching you mobilizing that, can we go to the other side and come back, sir? Thank you. Thank you very much, sir. Rajiv? Good afternoon, Rajiv.
Good afternoon, sir. Happy to present at Thoothukudi Medical College. To all so many of you are my teachers who are part of my career for 3 years between 2010 to 2013 at Tirunelveli Medical College. Dr. Rakesh, Dr. Sivanu Pandian and Dr. Nirmal. I think Meena Ranjani ma'am was my batchmate and all my colleagues and friends. Today I am very happy to present this to all my teachers also. So my presentation will be more of a PG oriented thing. So initially 2 minutes I will speak about some theory because I was told by Dr. Rakesh that so many PGs are there. So choledochal cyst, before I start,
Rajiv.
you need to know, sir, yes sir.
We also have Dean sir and our VP madam with us who have just entered and they are here to witness your presentation also.
Hi ma'am, hi sir.
Right.
And before I start, I think the PG should know the theories of choledochal cyst, how it would have developed. None of the theory is standard, but you have to know all the theories and you have to know the type of classification. Todanis is a must. You should know the diagram for theory purpose. And each type of Todanis classification, there is a certain type of management. So you should know that. Before I go into the video, any HPB case, major case, don't think twice, always do CT and MRI. There are papers and there are presenters saying that you need only CT, some presenters say you need only MRI. That is not the thing. Always CT and MRI. MRI for biliary anatomy, CT for arterial anatomy. So both we should know, because in a case of choledochal cyst and all, if you have a replaced or accessory right hepatic artery from SMA, we might injure it. So make sure that CT is done. You read the CT, take time, do an MRI, read the MRI, sit with your radiologist, spend some time with the radiologist before doing any HPB case. Whether it is a small case or a large case, doesn't matter.
Even for a gallstone disease, you want to do an MRI?
No, HPB. I am talking about proper HPB case, sir. Choledochal cyst, CBD exploration, injury, or any case next to gallbladder. Even we do a CT for difficult acute coli or anything, we always do it. Sometimes whenever we feel that that's not going to be a direct case, we always do a CT. But when you go into per se hepatobiliary case, always we have a CT and MRI.
Okay.
Must. Now we have a protocol, CT and MRI is must. We spend most of the, because once we went into transplant, we always felt that each gives us different information. So both CT and MRI before any HPB per se HPB surgery. So I will go into the video and yeah. Okay, this is a 34-year-old female who presented with recurrent cholangitis and abdominal pain, was evaluated outside with an MRI showing type 1 choledochal cyst, fusiform shaped. Later we did an CT to find out whether there is any replaced right hepatic artery, because when we are deciding on the right side of the choledochal cyst, we might injure or it might be posterior to it. So always CT to rule out accessory right hepatic artery. So in this step, first always we do the cauterization of the duodenum. Once we cauterize only, we can get, even in open, we have to do the cauterization at the beginning, so that we get to the lowermost end of the choledochal cyst. We have to go as below as possible to clip the lowermost edge of the choledochal cyst. See, what you are seeing is the superior portion of the IVC. So you bring down the duodenum, you have to bring down the duodenum from the hepatoduodenal ligament. Sir, you want to ask something?
Yeah. I could see some nodes there which while you're dissecting. In the case of choledochal cyst, are these nodes of any significance? As you
in CT, we had a doubt, sir, but in CT they suggested it was insignificant, it was small, and the characterization was not significant.
Okay, fine.
Whenever we have a doubt like this, the next investigation preoperative will be EUS.
Okay.
Like if I would have a doubt, if the radiologist would have told I need to rule out some malignancy, I would have done a EUS to rule out the characterization of the node which you told.
Okay, fine.
Okay. So as proceeding, once the duodenum is brought down, the retraction, see the port position is same as cholecystectomy. Only thing, we have an extra port on the right subcostal region of the patient. That port will be giving us, that port only will be forward. That port will be helping us for the retraction. So retraction is mainly by the extra port which we make on the right subcostal region. So once we get to the lowermost tip of the choledochal cyst, we clip it, double clip it. See, wherever we are using a hemolock, we always use a metal clip also on the specimen side. Once it is clipped, then we loop it. That is used for the retraction. And one more thing I have to mention here is we are using one suture to retract the gallbladder and the liver. So we are reducing the port. We are making one suture and pulling it with a cobbler needle. So the uppermost part of the dissection is done. So this is at the common hepatic duct level. Above the cystic. Yes, sir? Yes, sir. Can you hear me, sir?
Yeah, Rajiv.
Yes, sir.
We just had a power cut, just 2 minutes.
Okay,
Then
sir. Okay. Pass பண்ணிக்கலாமா? Full of it. நான் மாத்திக்கிறேன். நீங்க பாஸ் பண்ணிக்கலாம். வந்துருச்சான்னு தெரியலையே.
Rajiv? Rajiv?
Sir?
Audible?
Yeah, audible, sir. Can I proceed?
Yeah, through. Yeah.
Okay. So as we keep dissecting, we are dissecting at the common hepatic duct area. See, that is the cystic duct CBD, above the cystic duct CBD junction. So we have to go as above as possible in choledochal cyst, so that we at least go up to the confluence and we bring the choledochal cyst down, and then we do the anastomosis. So the main key point here is you always dissect on the cyst, so that all the vessels and the porta structures will go away from the cyst. So we are cutting it at the almost just below the confluence. Once this is done, the remaining specimen side we use it for retraction. So whatever loop we do, we retract with that. And with recent past and recent articles from GB Pant, we have started doing choledochal duodenostomy for all adult choledochal cyst. The one advantage which we see is, if at all patient develops any stricture or anything, we can deal it endoscopically. Once we do hepaticojejunostomy, it is very difficult. Either we have to do PTBD and wait, or doing the rendezvous procedure, going through the jejunum and getting into the anastomosis is very difficult. So for past 4 years, we are doing only choledochal duodenostomy for all choledochal cysts presenting at the adult age. So posteriorly, now we are doing only interrupted with 20 or 30 PDS, depending on the size and thickness of the common hepatic duct at whatever level we cut it. And anteriorly we might either do interrupted or continuous, depending on how difficult the anastomosis and circumstances is going to be.
No, will not.
Nowadays we are also keeping a barbed wire stent. Sometimes when the duct is very small, we keep a stent and we do the anterior layer. So barbed stent will be made of absorbable suture material, like we are using that whatever is coming like PDS, which is barbed, we keep it as a stent and we do the anterior anastomosis. If the CBD is very small, I mean if the CHD is, the diameter of the CHD is very small.
No, and will duodenum be pulled up a lot, Rajiv, for doing a hepatico or duodenostomy, right?
Yes, sir, but that is why we always mobilize as maximum as possible, sir, in the beginning itself. We have never had any difficulty. Maybe when you see the liver is retracted, you might feel that once liver falls down, you will feel that it's not hanging, or we don't need any supportive stitch to hold the duodenum also.
So we will get the opinion of a pediatric surgeon here. Venkatasaran sir is with us. He'll be doing Kasais. We'll ask him.
Sir, yes, sir.
Yeah, just a minute.
Yes, sir.
Rajiv, good dissection.
Yes, sir.
But as a pediatric surgeons, we used to do hepatic jejunostomy only.
Yes, sir. In pediatrics, we are doing hepaticojejunostomy only, sir. Only when they present as adult, we are doing choledochal, sir.
Okay. Yes, sir.
Okay, Rajiv. That was just a doubt.
Sir, should I move on to the next video or?
Yeah, you get ready with that.
Okay.
Just move to the other side and come back again.
Sure, sir. Sure, sir. Okay. Sure, sir. Sure.
Yeah, just wait for 5 minutes. I'll just go there and come back.
Sure, sir. Sure.
Sir, we are with you, sir. Yeah. Okay, sir.
What you can see only the bowel which is going out, that is the bowel which is forming the ileostomy. But only issues are beyond certain level. There is some stenosis type thing. That is not crossing beyond.
Oh, okay, sir.
Have to get opinion from urologist. Because recording is very easy. Just we have to take a few pictures and create a list for that is very easy.
Okay.
But not just for the purpose, because this patient has got mainly there is some obstruction and not able to pass urine normally through the back. So we have to get a consultation with the urologist before actually doing the technique. I mean, we can start reduce the pressure by using broad suture. You can is fix it and place a mesh outside. By placing a mesh, you take the power on the lateral side like this and take the mesh up to this level. So that we can actually reduce certain kind of procedures. So take the mesh at least 5 centimeters beyond and the loop should lie above the mesh.
Okay, sir. That's
And
a,
the loop should lie above the mesh and you can find here and here and all around.
that is the typical sugar baker you are talking about, sir. Okay.
But I have introducing the finger or catheter. It is come up to this beyond that it is the lumen is not
Oh,
filled and not able to cross the area.
okay.
The also I was introducing, but it is not going beyond that.
Okay.
Just want to have you have the consultation whether you want to reverse it before actually doing anything. If you want to reverse, then the surgery, only the revision will be done, they will not be placing any test.
Okay.
And we will place it anatomically.
Okay. So one doubt, sir. If you are placing, if everything goes well and you are placing a mesh, what will you do for the skin outside, sir? There's a big bulger. Can you show the outside video, sir? Ah. Okay, sir.
Yeah. Sometimes if you want to remove you do this one, they can make an incision, excise it, do a close to round plate and place the mesh inside. That's lab assisted approach you can do.
Okay.
Here, more terminal, you don't remove the skin at all.
Okay, sir.
Even in operator hernia, the skin will be there. Skin close, the thin skin will be there. Thereafter, if you leave it, if you see, it will totally get adjusted. And actually, in fact, it is better than actually remove the skin.
Okay, sir.
Yeah, thank you.
Thank you very much, sir. That was a wonderful dissection, sir. Only doyens like you can do that. A thimble bladder with the pancreatectomy and pseudomyxoma, all that you have done a great surgery. Thank you very much. That was a wonderful demonstration. Thank you very much, sir. Yeah, we'll come back again, sir. Rajiv? Rajiv?
Am I audible, sir?
Yeah, you're
Am I audible?
Yeah. You
Okay.
can go ahead.
Sir, this is again for the PG sake only this video, sir. Any cholecystectomy is not simple. See, this surgery what I am going to show was started by my resident only. After that, he had a anatomical abnormality intraoperatively where I had to take over and finish up the case. So, no cholecystectomy is taken granted because any bile leak is going to be a big morbidity to the patient. Whether mortality happens or not, morbidity is going to be really a bad thing for a patient. So, don't take any, for the case of residents, don't take any cholecystectomy as simple. Take your time while dissecting posteriorly, anteriorly, you look for the Kellogg's triangle and then only clip. As I go into the video, you will know why I am telling this. So, this was normal distal gallbladder with I think multiple calculi, but patient presented with 2 days of pain. So, after ultrasound and the LFT was normal, patient was taken up for surgery the next day after admission. So, after making the normal laparoscopic ports, after proper retraction, we were able to make out the infundibulum of the gallbladder. So, infundibulum is very important structure. You have to hold it with the left hand and retract, then only you will be able to make out the structures. So, once we retracted the infundibulum and the posterior, all the adhesions of the omentum was released, you can see the Ruvius sulcus also. Once the Kellogg's was dissected, as we started dissecting, there was some bleeding. So, from this point I had to take over from my resident. So, even now I didn't think that there is going to be an abnormality. Whatever bile you are seeing is from the staff's retraction port. She is holding the fundus, from there bile is coming. So, after I started dissecting slowly, all the fibers were removed. Still I didn't clip any structure. So, I had to get the Kellogg's triangle, see, after dissecting everything, slowly I felt there is some abdominal anatomy. Whatever bile is coming from the fundus, so I didn't worry about it. See, there is one structure coming from gallbladder bed towards the cystic duct. There is another cystic duct going and joining the CBD. I am sure you are able to make out the CBD, cystic duct. There is one more structure that is coming in the Couch triangle. See the one I am showing now. See. So once this, see, this is the artery. So that is the artery, and there is one more extra structure which is coming. So I took some time to take out all the structures and everything. First I clipped the artery. Once the artery was clipped, I had to decide whether I have to clip the duct near the cystic duct CBD junction or above it. So I dissected further to see from where that the extra abnormal bile duct is coming, I mean the cystic duct. So that might be from the liver bed directly draining into the cystic duct itself. So I dissected further to see where it is going and joining. So as I dissected further, I felt it is not coming from the gallbladder, it is coming from the liver bed. So I got opinion from my senior, that is Dr. Palnivelu sir, and then I showed him the anatomy. So we had to clip it above the junction where the extra duct is joining. Sir, can you make out, sir?
No, but that is okay. But one thing we are seeing down is the CBD, no?
Sir,
the
that
CBD
is the.
there.
Can
CBD
I
is
pause it
full.
and show you?
Pardon?
Marker la kattuma. Sir, this is the extra. கொஞ்சம் முன்னாடி போங்க. பாஸ் பண்ணிக்கலாமா?
Now, what is that structure? There is a both. There is one is bowing up, no? Or clipping something.
Sir,
yeah. What is that?
Bow? Marker, sir. That was the doubtful structure. That was the extra bile duct which was joining the cystic duct here, and this is the normal cystic duct which is joining. Yeah, sir. This is the CBD, sir.
That's what.
This is the CBD. This is the cystic duct CBD junction.
Okay.
But this was a anatomical abnormality we picked up during the procedure.
Oh, fine. What is that? That is CBD. That is another CBD.
That is another duct, maybe an abnormal or accessory duct from liver joining the cystic duct. Maybe a duct of Luschka, whatever you say, or accessory cystic duct it is. Okay. So this part of the liver might be draining through this duct to the CBD through the cystic duct.
Okay, understood.
So if I would have clipped it here, then I have to clip this also. I don't have a choice.
Yeah.
Then this will end up, this area of the liver which is draining through this duct would have gone for fibrosis, or your patient might develop cholangitis later.
Understood.
So instead of clipping here, I clipped it here.
Fine.
So post-operatively patient went on well. The only thing, if we wouldn't have dissected this area of Couch properly before clipping this, and if we had clipped it here before dissecting this area, we would have ended up in a disaster. Maybe I would have to open and find out what this is, or I have to do a bypass for this duct.
Yeah, that's the importance we always emphasize for the PGs, critical view of safety.
Safety, yeah.
Right?
So
that's what you are telling
proper dissection in this area is before clipping. It is better. If you have a doubt, call even whoever is outside the OT can come and help you, because your perception will be different from the person who is coming new into the OT and seeing what it is.
Yeah, definitely.
Other than the person who is assisting you, the third person might help you.
Fine.
Most of the time, they are the persons who will escape you from a disaster.
Yeah.
So again, I want to repeat for the sake of PGs, this is CBD, this is cystic duct, this is the accessory duct coming from the liver directly. So this is the duct draining this part of the liver. So clipping I would have done here. I will play the video, sir.
Yeah. Anyone in the forum who has experienced had such experience can share their experience. Dalton? Yeah, come.
So after this, the gallbladder was removed in a standard manner.
Rajiv,
Yes, sir.
Senior Assistant Dalton wants to share his experience, a similar experience with you.
Yes,
Please.
sir. Tell me, sir.
Yeah.
Sir, I had a case, the same scenario in which that accessory duct was opening into the CBD, sir, without
Okay.
going to the cystic duct.
Cystic duct. Okay.
So accidentally, I had an injury, but luckily I sutured it, sir. Patient had bile leak post-operatively, but settled
Okay.
down, sir.
Settle down. Okay. Okay,
So
sir.
tangential
So,
cut, I made a tangential injury, sir, without knowing it.
okay. So patient settled, and after that, no issues, no, sir.
No issues, sir.
Okay. Okay, sir. Okay. So you can see now I'll be able to show you after cutting how it is. See, so this is the cystic duct. So this is the abnormal duct which is coming. So this part of the liver will drain through this duct. The bile will go into the cystic duct and to the CBD. So we can't take a chance here. So always, whenever in doubt, wait, take your senior's help or something before clipping whenever you have a doubt in anatomy. So in this video, I will emphasize to all the PGs and juniors, no cholecystectomy is simple, don't take it granted. Thank you, sir.
Thank you, Rajiv.
Sir, I will take 5 minutes break and come back with either a radical cholecystectomy video or a CBD injury happened intraoperatively, how we managed it.
Yeah, fine. Anything will be fine. If you also have a CBD exploration, we have started doing that. So if you have
Okay,
that,
sir.
also you can tune us up a bit. Huh?
Sure, sir. Sure,
Yeah.
sir. Okay.
Yeah. Thank you.
Thank you, sir.
Rajiv? Rajiv?
Ready, sir?
Yeah, we are ready.
So, this is a short video after your lunch. So, as Dr. Rakesh sir was asking for a CBD expression for a long time from morning, so I had to find this from my hard disk. We have picked it up, little bit old video, but really good video. This patient, 42-year-old male, previously lap cholecystectomy done. Then after 3 years, patient again presented with cholangitis and abdominal pain. On evaluation, he had multiple CBD stones, one large stone with sludge. Later, twice ERCP was tried, but twice it was failed and the stone size was more than 1.8 centimeter. So we planned for laparoscopic CBD exploration. Going into the video, so as regular ports were made, whenever we do a HPP case, remember two things: put leg split, better the surgeon stands between the legs of the patient. And the second thing, harmonic is the best gadget you can use in the heparoduodenal ligament and dissection of that area. So between harmonic and ligature or any other thing, for dissection we always felt harmonic is better. So you can see the post cholecystectomy status. As we proceeded, in any case, liver retraction and then bringing down the duodenum is very important. Once you bring down the duodenum, you will be able to make out the CBD properly. So all the adhesions were brought down on the liver side, and then the CBD was brought down slowly without injuring the CBD. And we should be very careful. We should be very careful with the structures in the heparoduodenal ligament. Even in this case, we did a CT and MRI to rule out any abnormal arterial anatomy. So once the duodenum was brought down, we opened the CBD. Always opening of the CBD should be vertical, as if you do horizontally, you might injure the vessels which are supplying the CBD, the choledochal plexus. So it will be usually at the 3 o'clock on the 9 o'clock position. So we always in CBD expression open the CBD vertically. So here, as patient is in post cholecystectomy status, there is no cystic duct CBD junction, and PG should know any stone which we find out 2 years within 2 years after cholecystectomy, it is called retained CBD stone, which is diagnosed after 2 years. We call it as recurrent CBD stone. That might be one of your Viva questions, so you should know that. So the CBD is opened vertically. As we open, we are able to see the stone inside, but since the stone was little big, we had difficulty in taking out the stone. We had to extend the incision up and down. So with the retraction port, the staff is helping with suction. So we are able to see the stone, but because it is big, we couldn't get it out. So milking the CBD sometimes might spit the stone out, but still it is too big to bring it out. So we had to hold the lips of the CBD to take out the stone. Remember, the assistant camera person is very important here, and the retraction person also. So we had to break the stone and bring it out. So we couldn't take it out in toto. So after major struggle, slowly it was taken as a piecemeal only. So most of the time we use a choledocoscope to see any other stone is there in the common hepatic duct confluence and further and down also. Sometimes we use the Fogarty's catheter balloon. We railroad it to the duodenum. We inject the bulb with 5 ml and we retrieve it to clear the CBD. Some surgeons I have seen, they are using a nephroscope to see both down and up whether the stone clearance is there. I think you can see the stent is inside. So when patient had cholangitis, we had stented, but we couldn't remove the stone. So now the stent is also removed. So make sure you remove all the stones and put it in a bag. After that, we did a choledochor duodenostomy. So duodenum is open. And choledochor duodenostomy was done. See, now CBD is open vertically, but anastomosis is done horizontally. So here also most of the times the posterior layer we do it interrupted with 30 PDS, and anterior layer it depends on the surgeon. Sometimes we still do interrupted. My mentor Dr. Palnivelu, he always does interrupted only. Now we are slowly changing to posterior layer interrupted and anterior layer continuous. So before doing this anastomosis, make sure the CBD is completely cleared. The assistant surgeon and the camera surgeon are very important for you to help you do the anastomosis in a better way. When we are planning the CBD exploration, the right hand working port should be little below. If you, if the port is made in the epigastric region, as we do regularly for cholecystectomy, then we have to strain our shoulders. So better we put the port in the left subcostal region for the patient, so that it exactly comes to rotate the needle easily.
Rajeev, do you always routinely do a CD for all cases of CBD exploration?
Sir, now we have slowly shifted to CD, sir, and most of the, even the papers now it is coming that CD is enough. So unless when there is a CBD injury, we always think of hepatico-jejunostomy, or else we are very happy with CD results, sir.
No, not that. Here we do a primary closure of the CBD and come out. We just do a CBD exploration.
No.
Remove
Most of the cases we do primary closure only, sir.
Okay.
Here in this case, we weren't sure because large stone, so much of sludge was there. So boss thought that this case he asked us to proceed with choledochor duodenostomy.
Okay.
Only this case. Regularly we don't do choledochor duodenostomy for all CBD stones. It's only primary closure. So once interrupted sutures are made.
Do you use an nephroscope for the visualization?
Yes, sir. Yes, sir. We use a nephroscope.
Flexible or rigid?
Sir, it is a rigid only. We are having rigid only, sir.
Okay, so using a rigid.
So we have to make one port exactly at a position where it can go both down and above. So that port is very important, sir.
Okay.
The left hand working port is very important. You should have it in your mind when you are doing when you are putting the ports itself.
Okay.
We don't have a choledocoscope here.
Right.
And we don't have a flexible nephroscope also. We have a rigid one only, sir. Sometimes if we don't have, we use a laparoscopic ultrasound. Can you hear me, sir?
Yeah, you are very clear. Actually, we have started doing some CBD explorations here, right, in our institute. So we have some assistant surgeons who are doing it. So just ask them if they have got some real-time problems, some difficulties. I'll just ask them so that they can clarify.
Yes, sir. I'm ready to answer, sir.
Yeah, Dalton. Dalton is doing it regularly.
What is the criteria for closing it? Just doing a primary suturing of CBD or doing a choledochor duodenostomy? At which point we have to decide, sir?
If we feel that, in this case also, before going in, we did an MRCP. If we have a doubt that there is going to be a distal CBD stricture which has caused the stones, then if the distal CBD stricture is doubtful or we are sure that there is a distal CBD stricture, we have to do a bypass.
Okay, sir. So
if you are 100% sure there is no stricture, the ampulla is fine and everything, you can directly close it and come out.
So usually we do the case only after stenting, sir. So any relation
Okay.
to diameter, CBD diameter, sir?
No, sir. There's no actual criteria. But
sir.
only thing, if you are able to see with a nephroscope, well and good. If even the nephroscope is going with difficulty, or you are not sure that the stricture is going to come back, better to do on safer side choledochordionostomy or any bypass procedure.
Okay, sir. Thank you, sir.
The other surgeon who is doing it is Anita Perachi. She wants to ask something.
Yes, ma'am.
Sir, suppose if there is no stricture, then do you advise a choledochordionostomy?
No, ma'am. No. Now
Even if it is dilated, if it is above 1.2 centimeters?
No problem. Primary closure is enough.
It
Now
is enough.
the consensus is only if you have a doubt that there is going to be distal CVD stricture, then you think of bypass, or primary closure is the consensus now for CBD stones.
With the stent, is it?
Stent
Sir,
we will remove. You can remove the stent or you can leave the stent and take it later, because you are doing, you can do endoscopy and remove it later also.
Okay, sir.
Sometimes we leave the stent, or sometimes we remove the stent while before the anastomosis also.
Okay, sir. Thank you, sir.
Rajesh, sometimes we find that using a rigid nephroscope,
Yes, sir.
the opening gets very wide, very lengthy. It goes up to the duodenum.
That's what making the port exactly in that angle is very important.
Okay.
I feel even if the opening is going to become 0.5 centimeter extra, it is fine, unless you make sure that the CBD is cleared. Because now, as we move towards the primary closure of CBD, I feel that better we make sure that the CBD is completely clear.
Okay. The other thing is, do you always flush the CBD proximally also? Distally it's fine. Proximally also,
Yes,
do you
sir.
flush?
We flush proximally also.
What's the advantage? Because you'll just drive whatever sludge is there into the liver. What's the advantage of doing
No,
that?
sir. Usually it won't go into the liver. It will come out only. That is why even in open cases when we do transplant, we always flush the duct.
Okay.
Even re-exploration, even if we feel we open, we always flush the duct both proximally and distally.
Okay, fine.
That is even sometimes in a closed system, when you open the CBD, you might see pus.
Right.
In that case, always flushing the CBD both proximally and distally is a must.
Some
Even
people
last week,
some people advocate opening the cystic duct at the junction of the cystic duct CBD.
Yes, sir.
Do you do that? Or exploring through the cystic ducts?
What we do is sometimes we clip the cystic duct towards the gallbladder, cut the duct, so you will have the cystic duct cuff.
Yeah.
Through that we can leave the catheter, the balloon catheter.
No.
Now we have a 5 mm instrument which has a sheath in between, so you can put the catheter into the sheath, so it has a opening. When you open the jaw, you have a hole in between, through that the catheter comes.
Good.
You can guide the catheter into the cystic duct, into the CBD, into the duodenum, and you close it and hold it.
Okay, fine.
Then you can inject the dye, or you can flush, or you can do inflate the balloon and pull it up. So that instrument we don't. I have not seen in GEM also. I have seen in Hyderabad. That is a 5 mm instrument with a jaw with a hole in between, and you can railroad a catheter in between. So the catheter will come in between the jaw.
Okay.
So when you hold the cystic duct, automatically the catheter will go into the cystic duct.
Okay, fine.
In that case, you explore through the cystic duct. If you are 100% sure that CBD is cleared of the sludge and everything, you can clip the CBD and cystic duct and come out. Okay. So the ultimate aim is clear the CBD, and there should not be any distal CBD stricture.
Okay. Any other questions from the floor? So if nothing more, we'll close the session. And
okay.
Rajiv, from the audience, if you have time, can you show us 2 videos? We want 2 videos. One is the port closure technique of a 10 port closure technique of GEM. You use that needle and do it, no?
Yes, sir.
If you have a video of that, if you can show, that is one thing. And
Okay,
second thing,
sir.
people want to have a glance of a pancreatic surgery, like LPJ or Whipple's anastomosis or something. They just want to see how you do it laparoscopically in a pancreas. A short clipping, if you can show for another 10 minutes, we'll be happy.
Distal pancreatectomy is fine, sir.
Yes, PGs, distal pancreatectomy. Or you want to see anastomosis? What? What you want to do in the pancreatic surgery, no? Tell them quick. They want to see anastomosis in the pancreas.
In the
LPG,
pancreas.
left LP, lateral pancreas anastomy.
I'll just check, sir. First, I'll show the port closure. I'm just getting the video.
Okay, fine.
2 minutes, sir.
Yeah, sure.
Can I go offline and come back?
Yeah, sure.
Rakesh, sir. Hello? Hello, sir. Sir, am I audible? Hello, sir.
Yes, Rajiv, you're audible.
I've got the 2 videos, sir, but both are not my videos. I will try to talk whatever I can. I'm also seeing this video for the first time, but it's
No
okay.
issues.
For the PG sake, I will continue. Okay.
Yeah, no worries. Yeah.
So this is the port closure video, sir. Usually any 10 port we do, we close the port. So we are using the same technique for all the ports. So once the port is removed, this is the cobbler needle which we use. We insert the ethylon, 20 ethylon. We come through one side of the port first, then hold it with the other instrument, then the other side, take the same suture and bring it out. You got it, sir?
Yes, Rajiv. Yeah, you're saying.
So it is a protocol that we close all the 10 mm ports. So 5 mm scope is ready sometimes. So we make sure all the 10 mm ports are closed by the end of the surgery. So this is the other way of doing the port closure. Did you see, sir?
Yeah. This is the thesis topic of one of our PGs. So I thought
Okay, sir.
ask them to, she can have a first-hand view of that.
So I will go into the Whipple's procedure, sir.
Yes,
Shall
Anupama
I
in the
proceed
hall?
with the Whipple's?
Yeah, we can. You
But
can.
I will be concentrating on the anastomosis part. Okay, sir? Is it okay?
Pardon?
I will be concentrating more on the anastomosis part as
Yeah.
the PGs wanted.
Okay.
So this is almost at the we are going to transact. So we are taking the stay suture on the patient side, sir.
Okay.
So I am starting from this part where the jejunal limb is jejunum is transected and the anastomotic limb is got ready. So this is where you dissect the duodenum and you bring down the transverse colon. So this is the specimen. Now I think you can make out the specimen is in my left hand.
Yeah, clearly.
So I am bringing the jejunum to the right side of the patient. Now we are transecting the pancreas.
Yeah.
So we usually use harmonic and we change to scissor whenever we think we are cutting the PD. What you are seeing down is the portal vein.
Yeah.
So what is left out at this point is only the unsned process. Unsned process dissection is done by the rubber band technique where there is gradual retraction. See, once the rubber band is retracted, slowly you will feel that the dissection becomes very easy. So this is the inferior pancreaduodenal veins which are dealt with.
What are you
So
telling
we are
us? The rubber band is sutured to the anti-abdominal wall.
We are pulled through that. You saw that the port closure needle, no, sir?
Yeah.
So what we do is we hook the rubber band with the ethylon, and with the cobbler needle we pull the rubber band out. The outside the cobbler needle will be pulled, so the rubber band will be pulled.
Okay.
So that makes the dissection little easier. So as you dissect, it will be moving away. So this is the CBD part. So CBD is done at the end.
Okay.
So we are cutting just at the common hepatic duct level. So the specimen is retrieved. This is the post resection picture. And we make sure which loop you are bringing up. So, we do it through the retrocolic fashion only. So we first place it in the correct position, which will make the anastomosis very easy. So we usually use the infant feeding tube, sir, before the anastomosis.
Okay.
Now what we are doing is the Blumgard stitch. Two, three Blumgard stitches taken. Make sure the stitch doesn't go through the duct. So on the farther side, the Blumgard stitch is taken. Now posteriorly also we take 2-3 sutures to hold the pancreas. See, the ultimate aim is the pancreas should be completely encaved into the jejunum. So the leak rate is very less. There are humpty number of anastomosis which we can do, but it depends on the surgeon which is best for you, which you have got trained. Try to emphasize that one. See, we always put a stent. That feeding tube acts as a stent between PJ.
Okay.
We leave the stent. That stent will be there at least for 2 weeks. Then patient usually the stent falls off and passes the stent in his stools. So we leave the stent at that place. Even here, there is no standard technique. Now only we have come to a standard technique where we take 3 Blumgard stitches, then we do interrupted PD, that is mucosa of the pancreatic duct to the mucosa of the jejunum, then we close the Blumgard stitch. So these are all supportive stitches to hold the pancreaticojejunostomy. See, there should not be any tension over the anastomosis, so we did that. You can see the portal vein and the common hepatic artery for the sake of PGs. So as I said, whether interrupted or continuous depends on how big is the duct and how dilated the CHD is. So here we are doing only interrupted sutures, and anteriorly we are doing continuous. So pancreaticojejunostomy, then hepaticojejunostomy, and then we would have done a gastrojejunostomy, which I didn't show in this video. Fine, sir?
Thank you, Rajiv. That was a nice demonstration and sharing of knowledge. Thank you so much.
Thank you very much, sir.
Very proud to have you there as a faculty.
And we are expecting one similar kind of meeting from Dr. Sivanu Pandian from Tirunelveli Medical College also, sir. That will be my alma mater. So
yeah, sure. I thought
sooner
that
or later, sir.
you could have come personally here to deliver some talk. It would have been much better. Anyway, we'll have it in the future. We'll have
Yes,
so
sir. Two things.
Yeah.
Today it was not my OT day, so I had to jump in and chip in to show all these videos.
But that was
Another
great.
thing, my team has left to ISGCon for the ISGCon conference to Patna, so I couldn't travel there. Otherwise, I would have. It would have been my pleasure to come there and join you.
Thank you so much. We expect you in the future meetings too. Thank you so much.
Thank you, sir. Thank you, sir. Signing off from GEM.
Thank you. Thank you so much. Thanks everyone at GEM, especially to your mentor and doyen of laparoscopy, Dr. Palnivelu sir, and his right hand, Dr. Pathasarathi sir. And thanks for the operating surgeons, Bharat Kumar, Saravana Kumar sir. Thank you so much. And also to Dr. Harish for having demonstrated a wonderful video. And thank you to you too and all your team.
Sir, I would like to thank Mr. Pasupati and Alagar sir for helping me.
I was about to mention his name, the backbone of all your transmission. Yeah, he was coordinating with me for the last 2-3 days. And thank you so much, Mr. Pasupati. He's with you?
Yeah, he is there, sir. He's there.
Can you show his face? Thank you, Mr. Pasupati. I heard a lot about you. And you had the past 15 years, you have been doing all the editing, video workshop work for GEM. Thank you. It was a wonderful transmission. Very good quality, high definition 4K transmission. We enjoyed the surgery. Thank you so much. Thank you, Rajiv.
Thank you, sir. Bye, sir.
Thank
Bye.
you. Thank
Good
you.
day, sir.
Signing off now. Bye. Sendil sir. Hello, Sendil sir.